Hola, muy buenas tardes y bienvenidos todos.
Good
Bienvenidos
afternoon and welcome to our training day on AUD, alcohol use disorder, designed for hepatologists and gastroenterologists. Now, here we have the ALEH, Latin American Society Association for Liver Studies. It's for all of us gastroenterologists and hepatologists to learn about this very frequent disorder, alcohol use. We have 8 speakers lined up today. We'll be going over the different topics. So I'd like to call upon you to prepare for the Q&A, so you can relay any questions or comments you have for our roundtable. We also have interpretations, so you may select the language you wish to listen to, English or Spanish. Today I'm moderating with Dr. Luis Diaz, a liver specialist who has been very productive these last few years in terms of alcoholic liver disease. So it's a pleasure to be up with you today moderating from the Catholic University of Chile. I'm Juan Pablo Arab, a hepatologist and gastroenterologist, director of transplant with living donor transplant, also at the Catholic University of Chile. So without further ado, we'll be having our first talk. Dr. Dunn Winston, an excellent friend of ours, will be giving a talk on screening on alcohol use disorder in gastroenterological visits, when to refer to a psychiatrist. He is a hepatologist, AP at Kansas Medical Center. His research interests are alcoholic liver disease, steatohepatitis, and among his publications, he was a creator of the ANI score, which allows to discern between alcohol liver disease or a fatty liver disease. So thank you, and the floor is yours, Dr.
I would like to thank Dr. Arab for this opportunity to discuss with you about the alcohol use disorder screening in the medical consult. We are going to discuss about 3 sets of the tools. The first is the questionnaire. The second is the direct biomarkers of alcohol use. And finally, we will discuss about the indirect biomarkers of alcohol use. So first, we are going to discuss the questionnaire. The very simple questionnaire that we have is the audit. The audit comprises 10 questions. It's a 10 questions scoring system. It is the first 3 questions is the quantity frequency questionnaire that provides a retrospective estimate of the average alcohol consumption. It is appropriate for all patients with liver disease. An audit score of greater than 8 is considered a positive screening for alcohol use disorder, while an audit score of 15 for men or 13 for women have a 100% specificity but low sensitivity for detecting alcohol dependence. So I would like to bring your attention to the first 3 questions here, which we will also see in the next slide. The audit C is basically a shortened version of the audit. It is also a quantity frequency measure. It is appropriate for the general medical setting, such as the primary care. A result of greater than or equal to 3 in women or greater than or equal to 4 in men are considered a positive screening result for hazardous alcohol consumption. So some people think that the quantitative frequency measure is not good enough and propose a daily estimate measure. The reason is that the quantity frequency measures is not sensitive to sporadic days of heavy drinking. The problems with the daily estimate measure, that is using a method such as timeline throwback, is that it is extremely time consuming. On average, it takes about 20 to 30 minutes to complete a 1 year of timeline throwback. And there is a recent meta-analysis that shows that the result of the timeline throwback, that is the daily estimate measure, is very closely correlated with that of the quantity frequency measure, and perhaps it does not justify the additional time. Lifetime drinking history would be appropriate for patients with severe alcohol-associated liver disease, that there is a need to assess regarding the amount and time frame of alcohol consumption. And for example, the grams of alcohol per day for a specific period of time. It may allow us to have a better correlation of the liver-related outcome, and also understand the relative contributions of alcohol to individual susceptibility, such as genetic background or obesity. Next, we are going to move on to the biomarker of alcohol use. There is a product formed during the damaging products in tissue and organ from alcohol use, and they include the AST to ALT ratio, CDT, MCV, and GGT. Note that these changes are long-term changes. So after a patient has been abstinent from alcohol, these changes does not immediately revert to normal. And then the alcohol undergoes oxidative metabolism, the majority of alcohol, but about 1% of alcohol undergoes non-oxidative metabolism. And the end product includes ethylglucuronide, ethyl sulfate, as well as phosphatidyl ethanol that we are going to discuss about, that offers us a window for detection after a patient has been abstinent for a short period of time. The ethylglucuronide is the result of enzymatic conjugations of ethanol with the glucuronic acid. It is eliminated in the urine, and therefore it can be detected in the urine. After alcohol consumption, a maximum concentrations of urine ethylglucuronide, that is ETG, is reached in about 5 to 6 hours. And in approximately after the first 10 to 12 hours, 80% of the urine ETG is already eliminated. And after the first 24 hours, about 95 to 99% of the ETG is already eliminated. Although study suggests that ETG can offer detection up to 3 to 5 days after last alcohol use, this really depends on the amount that the patient consumed, as well as the chronicity of alcohol use. Generally, it's suggested that ETG is 62 to 89% sensitive, and with a specificity of 93 to 99%. Of note, a low level of ETG can be detected in non-drinker and in children, and these are less than 100 microgram per liter. And therefore, the cutoff that we should use for patients drinking should be higher than 100 microgram per liter. Ethyl sulfate is very similar to ethyl glucuronide. It is the result of enzymatic conjugation of ethanol with the superfamily of cytosolic sulfonyluretransferase. One problem that arises is that there is possibility of genetic polymorphism that can affect the detection. So again, eliminated in urine. So this can be ordered as a urine test. And the half-life is slightly shorter. After the first 10 to 12 hours, 92% is eliminated. And after the first 24 hours, 99% is eliminated. So this graph shows the detection after the patient has stopped drinking for 3 days versus 4 to 7 days. As we can see, after a patient has stopped drinking for 3 or less days, the level of ethyl glucuronide is usually very high. We can see in the chart is the median and the intraquartile range is usually sufficient for detection. However, at 4 to 7 days, then it overlaps with what we considered would be the acceptable level for non-drinkers, and the sensitivity becomes substantially lower. What about the impact of a hand sanitizer? This is a very common excuse that has been brought up by our patients who was found to have positive ethyl glucuronide. So this study shows 30 subjects, and they were asked to use a hand sanitizer with a 62% ethanol every 60 minutes, every 30 minutes, or every 15 minutes for 8.5 hours. This would mimic and in fact exaggerate a little bit of the work schedule of a health professional. And what they found is that among those that use hand sanitizer for 60 or 30 minutes, the ethyl glucuronide were negative, and only in 1 out of 2 patients that use hand sanitizer of every 15 minutes, there is a low positive level at 50 microgram per liter, and that is still below what we considered to be acceptable for non-drinker, which is 100 microgram per liter. So here are the common reasons for false positive and false negative. Yeast contaminations of urine is often quoted. However, when I try to go back to the reference, it all goes back to an article that is back in the 1990s that really talk about detecting urine alcohol rather than urine ethyl glucuronide. So I cannot find any real evidence that the yeast contaminations in a patient with diabetes can cause a positive urine ethyl glucuronide. Hand sanitizer that we talk about, mouthwash containing alcohol, and prescription products are also the 2 most common excuses that my patients come up with after they were found to have a positive test. False negative includes a urinary tract infection, and the reason is that bacteria in the setting of urinary tract infections can disconjugate the urine ethyl glucuronide. And urine dilutions, that means the patient pouring water into the urine, this can be addressed by measuring the urine creatinine to ethyl glucuronide ratio. Now we move on to the phosphatidylethanol. So ethanol attaches to the phosphatidylcholine by a trans-phosphatidylation reaction through the enzymes of phospholipase D, and that leads to the formations of phosphatidylethanol. The phospholipase D prefers the alcohol molecule over water as a substrate. Of note, when we refer to phosphatidylethanol, it is not one molecule, but actually a class of molecule with a common non-polar phosphatidylethanol fragment that is attached to various fatty acid moieties, as we can see in the table in the right upper hand corner. The synthesized phosphatidylethanol is attached into the cell membrane of red blood cells, and therefore it can be measured by blood level. It is the only blood biomarker that is said to have no false positives, and it's also not going to detect a single intake of high dose of alcohol. It detects chronic alcohol intake. It is possible to detect alcohol intake up to 3 to 4 weeks ago, but as we can see on the figure in the right lower corner, that after the consumption of 1,000 grams of alcohol over weeks, and then the patients are becoming abstinent, that the sensitivity of phosphatidylethanol gradually decreases, and by day 14, the sensitivity is about 80%. Generally, it is quoted that the sensitivity is 90 to 99%, and the specificity is at 100%. Also note is that the phosphatidylethanol should be confirmed by liquid chromatography and mass spectrometry, and not be based on the ELISA test result. This also applies to the other two tests, the ethyl glucuronide and ethyl sulfate. They should also be confirmed by liquid chromatography, mass spectrometry. Now let's move on to the indirect biomarker of alcohol use. So this is a marker that we have developed, the Alcoholic Liver Disease, Non-Alcoholic Fatty Liver Disease Index, ANI. The purpose is to detect if there is an alcohol basis for fatty liver disease. It comprises of MCV, AST-ALT ratio, and BMI and gender. There is an online calculator that is available for your use if you search for that online. The derivation cohorts includes patients with evidence of steatohepatitis, and some of them have alcoholic steatohepatitis, others have NASH. And then we have 3 validation cohorts, includes a case control mix of patients with alcoholic liver disease and non-alcoholic fatty liver disease. We also have ambulatory patients that were enrolled in a study to validates the utility of CDT. And we have end-stage liver disease patients who were listed for liver transplant and has been abstinent for at least 6 months. And we see that the ANI is superior to AST-ALT ratio, GGT, and CDT in detecting an alcohol basis for having liver disease. I would like to explain a little bit about the ANI is the scoring. The score is a logit score. So having a score of 0 would means that having a score of 0 would means that there is a 50-50 possibility of having the alcohol basis for liver disease. And having a score of 1 would means that there is a 75% possibility of having an alcohol basis. But having a score of -1 would means that there is a 25% possibility of having an alcohol basis for liver disease. So in summary, audit is an excellent screening test for all patients with liver disease. An audit score of greater than 8 is considered a positive screening for alcohol use disorder. The ethylglucuronide and ethyl sulfate offers a longer durations of detections than blood alcohol level and breath test, but the detections beyond day 3 has very low sensitivity. Phosphatidylethanol offers excellent sensitivity and specificity at 2 weeks. And the ANI predicts an alcohol basis for liver disease and not recent alcohol consumption. Well, thank you very much.
Muchas gracias, Dr. Winston Dunn.
Thank you very much, Dr. Winston Dunn, for your excellent presentation. I'd like to introduce Dr. Juan Pablo Robledo, AP at the School of Medicine at the University of Chile, at Gastroenterology and Hepatology at the Clinical Hospital of the University of Chile, and President of the Chilean Association of Hepatology. His talk will be on getting over barriers from patients for reporting alcohol use and accepting treatment. Dr. Arav and Dr. Diaz for having invited me to participate today for the special interest group for alcohol use from Aleh. I've been asked to talk about the barriers patients perceive when trying to obtain treatment for AUD, alcohol use disorder, in terms of diagnosis and treatment. We have barriers coming from the patients, the health systems, and health professionals. I'll be focusing on the patients and the health professionals. Not so much on the health systems. I'll be looking over problems with integration health teams, referral problems, and limitations in terms of access. In terms of patient barriers, we have a lack of knowledge in terms of alcohol use disorder. For example, a patient might not accept that AUD is a chronic disease. They consider that they only need treatment for their liver disease and not for their addiction problem. They think that they don't need help, that they can do it themselves to drop their addiction. They don't think that the chance of relapse is very high, and because they're not aware of treatment options. Often patients won't report their actual alcohol intake. Sometimes they'll think it's even too late to treat AUD due to the chronic liver damage already set in. And often there's concern due to confidentiality. Since people have concerns of these types of things leaking out in their work and family groups and social groups. Other patient barriers would be the fear due to social, family, and healthcare team stigma. Sometimes they'll have to deal with shame, guilt, and social isolation. They might be dealing with comorbidities such as depression, anxiety, or other psychiatric conditions. There can be low motivation for making the change. Sometimes there isn't a good network supporting the patient, and sometimes there's even socioeconomic problems. And we can see in a study that lack of motivation was present in 60 to 70% of the cases. This is a study done with internal medicine specialists, gastroenterologists, family medicine specialists. There's no motivation to treating these patients. For example, there's not the same motivation as there would be for treating what we tend to treat, such as high blood pressure, diabetes, etc. This study also highlighted a lack of training and support in about 50% of the cases. There's also something erroneous we tend to do as professionals, which is to guilt trip or blame or manipulate the patient. Sometimes there's poor communication. Sometimes there's a weak therapeutic alliance. And sometimes we can even deal with wrong diagnosis. We might focus on the liver when in reality, a psychiatric disorder might be leading to alcoholism, which is the cause of those liver disorders. Now, in terms of overcoming these barriers, in terms of motivational enhancement therapy, or MET, this has been used and developed by Miller and then with Rolnick in 2013, where they formulated this method of treating patients mainly with addictions. However, it has extended to other disorders in the psychiatric arena or psychological arena. And they comment that commitment is a prerequisite, an essential requisite for all diagnostic and therapeutic process. So up next, there'll be another talk dealing with some of these aspects, but here the commitment is a way of getting setting an agreement on how you will proceed with the patient and that you will be embarking on with the patient together. Now, with this commitment, you need to create communication centered on the patient. A commitment is essential for evaluating addictions. Patient participation is vital in the process. And this encounter should be attractive for the patient and not just an act of compiling data from the patient. So it's not just a medical visit. These are many interviews or brief interventions. So it's not just one visit, it's a long road. And preparation is different. Not all patients are the same. The degree of commitment can also vary. But there has to be commitment, which is the cornerstone. The basis of commitment is empathic understanding. We need patience and the ability to understand the alcohol use problem from the medical, psychological, and social perspective, from the patient's viewpoint. we need to be able to listen attentively and reflect with precision in terms of the meaning of what the subject is saying, without imposing our ideas. The change has to come from the patient's reflection, not from what you tell them. We need to show complete interest and focus on how the patient perceives their environment and their problems. Having empathy is a clinical practice which is based on having good predictive factors in terms of outcome. In terms of fundamental abilities for attaining commitment, we need the capability of taking on the problem with sensitivity and tact. We need to be able to convey respect and compassion, acceptance. There has to be camaraderie. We have to link our screening with the proper interventions. We have to avoid the use of labels such as alcoholic, drug addict. We should avoid criticizing or blaming. We have to listen attentively, be non-confrontational, and learn to deal with the patient's resistance. With some basic communicative skills, or OARS, for communication skills. For O, we have open questions, A, affirmation, R, reflective listening, and S, summarize. In terms of the open questions, as we know, these are questions that can't be fielded with a yes or no, or just a brief response. Open questions will allow the subject to speak and elaborate on their point of view. And it helps to build communication with the subject and gives us information on how the patient perceives their problem. It helps them to explore the reasons for making changes. For example, we have to try to make questions that will come with a yes or no answer. We should avoid those. We should ask some things like, what do you think about what happened? So what are you thinking about this? What do you like about this? Or tell me about the last time you felt good without drinking, and so forth. Those types of questions are more favorable. Here we have examples of closed questions. Do you feel depressed? Yes. Do you like alcohol? Yes. Do you want to keep drinking? Or do you want to go off the habit? Do you have problems with your wife or spouse due to alcohol? Yes. How long has gone by since the last time you stopped drinking? 3 days. This is an example of very brief questions that you should avoid. Here I have open questions. What do you like about alcohol? And the patient responds, well, when I drink, I feel less sad, more integrated into the friends groups. I have a better time and I'm feeling more relaxed. Another question. What do you think about your style of drinking in the last months and the problems it has brought you? Well, sometimes I'll drink more than I should. I become aggressive. I can't remember what happened. My wife gets angry at me and doesn't speak to me. And we've had problems, serious problems because of this. In what other ways has your relationship with your wife been affected due to your use disorder? Well, we're more distant. We speak less. We argue more. She's concerned and she wants me to undertake some sort of therapy. So that's why I'm here. So those open-ended questions will allow for the patient to get deeper into the subject. In terms of A and ORs affirm, here we're dealing with declarations which acknowledge the patient's strength. They help with the relationship, and in the affirmation, you give in declarations that would suggest appreciation and an attempt to understand the problems and perspective of the subject, and it helps to build trust. For example, I understand the efforts you've done to talk about your alcohol problems. You're a very strong person, and you're still striving to change. It's impressive. Have you been able to come through all this? So here's an acknowledgement to the patient, to all their efforts, their work. it's important to take the different opportunities for positive comments. For example, a patient, for example, will say, I've been homeless for quite some time. I've done some pretty awful things to get money. I've been hungry. I've gone hungry. I've also been arrested. Well, you've gone through some difficult times, the therapist says. You're a true survivor. Not everyone could go through what you have. That's an example of an affirmation. After such a statement by the patient. In terms of the R in ORS, reflection, this implies using declarations from the treating physician, which reflect the meanings and underlying feelings of the subject. It reflects an attempt from the therapist to understand the problems and perspectives of the patient, their views, and it can be used to clarify what the subject wants to say, and can be used to emphasize ambivalence on alcohol use disorder, and to bolster declarations that would indicate that the subject is thinking about instituting change. You can start by repeating what the patient has just said, throwing it back at them, but it's more than that. We have to make and try a reflection as a hypothesis based on what we hear, what we observe, and based on our own experience. While you reflect, it's not about being in agreement or in disagreement with the subject. It's not about giving advice or offering solutions or diagnosis. If the subject continues to elaborate, if the patient, as I said, if they continue to elaborate, that means that our reflection was favorable and that it made them look at their problem more deeply. The therapist says, for what you're telling me, it's probable that alcohol, you're using it to overcome anguish and sadness problems that you've been having for quite some time. Based on what the patient had been telling us. And the therapist also says, from what you're telling me, the alcohol is causing significant problems. You don't remember, you become aggressive. It's also led to marital issues. That's based on what was said in the first case. Finally, to summarize, you bring together the sum of the reflections you've made, you prepare the patient for considering change, and it also improves the therapist's reflexive listening ability. So, for the therapist has said, up till now, you've told me that sometimes you drink so much beer that you can't remember what happened the night before. Your wife is fighting more and more with you about this, which is bothersome. What else? Or the therapist said, I wonder if this feeling of anguish that you talk about is something that similar to what you felt when your wife said that she wanted to get a divorce a few years ago. It feels that you've lost control, and that's had quite an effect on you or an impact. This process of these brief interventions, these would be no longer than, let's say, 10 minutes, not long sessions. You have to work on some reflections, get them to reflect, and to work on this through time. So the subject over time has to discover what changes they need to make. The idea is not to impose on them our ideas or to blame them. Commitment is goal number one, the task number one. It sets the foundation for the diagnostic and therapeutic process, such as screening, motivational, enhancement therapy, different kinds of individual or group therapies, or pharmacological therapy, if necessary. It's not just the treatment you're giving, but how you're giving it. Therapeutic relationship is vital for good outcomes. Empathy is essential. The ability that is learned from listening attentively with total attention. All of this has a positive impact in patient addiction outcomes. The patient cares a lot about how we give them information. They care that we're honest, and they care about creating a relationship of trust. Here, I'd like to leave some links with you for learning resources. We also have videos that show some brief interventions and how to use these communicational tools, which are useful. And it's important to improve reflecting capabilities in our patients, their ability to reflect. Here's some more learning resources, some books that you can even find online from different organizations, as you can see. Thank you very much. Thank you very much, Dr. Rolero, for the wonderful presentation. We'll be looking right now at AUD DSM-5 criteria given by Dr. Sofia Herrera, an adult psychiatrist from the Catholic University of Chile with a master's in dependence in the University of Barcelona, as now is staff of the addiction unit at UC Cristos Health Networks. The floor is yours, Dr. Herrera.
I would like to thank you for the invitation. I'm going to speak about AUD and DSM-5 criteria. An overview of my presentation. I'm going to speak about the classification of AUD and DSM-5 and see where we are starting from. Then alcohol-related disorders, changes from DSM-4, which is the prior version to DSM-5, and comparison with ICD-10 class conclusions. In order to start, we have to say something about psychiatric nosology, the classification of disorders in psychiatry, so as to understand how to reach DSM-5. Nosology is the branch of medicine, the purpose of which is to describe, explain, differentiate, and classify the wide variety of diseases. Understanding this as clinical semiological entities, usually independent and identifiable based on suitable criteria. For psychiatry, it is the classification of mental diseases and behavior disorders, and it is very necessary for communication amongst clinicians, researchers, to understand the etiology of diseases, to understand prevalence, health plan, insurance. So it is very important to understand the way in which we classify different disorders. And in psychiatry, this is really important since we do not have any other tools to be able to distinguish from one disease from another, or to make a diagnosis, the neuroimages, for example, or pathology that can help us and say, look, this is schizophrenia, bipolar disorder, alcohol use disorder. So this is a timeline. This is a very interesting paper about the history of the classification of substance use disorders. We can see that the DSM regarding mental disorders appeared quite recently. In the 18th century, there were some texts about intoxication with alcohol could be a disease. And mid that century, alcoholism was introduced, and there are efforts from different societies to moderate consumption. And after the Second World War, and with the less importance of Germany in psychiatry, attention is turned to North America. And in 1952, the APA launches DSM-1, where alcohol use disorder is under psychopathic personality disorder. Imagine that. that was because of the influence of psychoanalysis at the time. Then DSM-2, there was an effort to take it, separate it from personality disorders. It wasn't until DSM-3 that they succeeded, and in DSM-3 and 4 and their reviews, changes were made in the duration, the name of disorders, severity, and finally, up to DSM-5, which was published in 2013, which is the main topic of my presentation. DSM-5 is a diagnostic tool that includes all of the mental disorders categories, and for each one of them, there is a list of symptoms, statistics, and to a lesser extent, suggestions regarding treatment. It is not a book containing treatments. And the chapter that contains alcohol abuse is the one named disorders related to substances and addictive disorders. Amongst alcohol-related disorders, those appearing in DSM-5 are AUD, alcohol intoxication, abstinence, and other disorders induced by alcohol, such as affective disorders, psychotic disorders, sexual disorders, sleep disorders, and neurocognitive disorders, besides not otherwise specified alcohol-related disorders. These are disorders that meet some criteria, but they do not belong to that classification. The AUD corresponds to a problematic pattern of alcohol use that causes a deterioration clinically significant, which manifests itself by at least 2 of the following facts in a time of 12 months. Later, we will see the criteria one by one. Sometimes in the literature, there are 4 clusters. Deficit control, that the patient has lost control over the substance, social deterioration, negative consequences brought about by alcohol use, risk consumption or hazardous consumption. Despite physical and psychological risk, the patient continues to use the substance. And the last 2 ones called pharmacological criteria, because of their more biological connotation, which corresponds to tolerance and abstinence.
Y además de cumplir al menos 2 de los criterios anteriores.
Besides meeting at least 2 of the previous criteria, there is also the classification through specifiers. In this case, severity and course. This gives the characteristics regarding dimension to DSM-5. DSM-5 organizes their criteria by category, but also within each category, the diagnosis can have a different degree of severity. In this case, severity criteria. AUD can be mild when the patient meets 2 or 3 symptoms, moderate when the patient meets 4 or 5 symptoms, and it is severe when it meets 6 or more symptoms. And also there is a specifier of course, the way in which this disorder has unfolded. We have the initial remission category when the patient stops meeting the criteria for a period from 3 to 12 months. Sustained remission when the patient stops meeting the criteria for a period over 12 months. In a controlled environment when the patient stops meeting the criteria since he is in a place where he cannot have access to alcohol. Another interesting thing are changes from DSM-4-TR, which is a revision, which is the previous DSM, to DSM-5. DSM-5 integrates both disorders described by DSM-4, such as abuse and dependence, which is probably what was studied the most in undergraduate in the School of Medicine, in just one disorder due to alcohol use, with the specifiers of mild, moderate, and severe, and coarse as well. In DSM-4, for abuse, you had to meet at least one criterion, for dependency, at least 3. And in DSM-5, it is agreed that you have to meet 2 more criteria, and the severity specified is based in the total number. DSM-5 eliminates the criterion legal problems and includes another criterion called craving, which could be translated in Spanish as longing for using the substance. It has craving has a physical and psychological connotation, characterized by an intense wanting to do something, whether use substances or doing any other activity, something that is very difficult to stop doing it. And DSM-5 modifies, when updated language, some descriptions. All right. Now, ICD-10, which is the other classification for psychiatry. ICD-10, speaker corrects herself, ICD-11 has some criteria which relate to AUD, leaving aside criteria of intoxication, abstinence, and those related to alcohol consumption. So there is those 3 ones: noxious use episode, pattern of noxious consumption, and dependency. Episode of noxious use corresponds to a single episode of use of alcohol that caused damage to the physical or mental health of a person, or produced a behavior that can damage the health of other people. And that criterion summarizes how to cause that damage. And the noxious pattern of use, it is the same description regarding damage to the person or third party, but use of alcohol should be evident for about 12 months. Episodic, or 1 month if it is continuous. And dependency is defined as alcohol use regulation disorder that comes out of continuous use of alcohol. And then there are several elements specified which are similar to those appearing in DSM-5. Those differences between DSM-5 and ICD-11 would lead to a long discussion about for and against, but it is very important to know that these are not the same criteria. It is interesting to discuss how those differences would allow us to tackle some of those episodes. How can we use the criteria of DSM-5 in our office? Well, we have to see the way of asking each criterion. This has been suggested by an attachment to DSM-5. We say that a problematic pattern is required, plus a deterioration or clinically significant malaise in a period of about 12 months. So the first criterion, alcohol is used frequently in amounts that are superior or during a time that is longer than foreseen. Well, there you see how you can ask that. When you drink, have you noticed if you drink more or for longer? There is also a persisting wish or failed efforts to quit or control alcohol use. A lot of time is invested in activities necessary to obtain alcohol, consume it, or recovering from its effects. A craving or powerful desire or need to use alcohol, recurrent use of alcohol that leads to not meeting your fundamental duties at work, school, or home. Continuous use of alcohol despite suffering from social interpersonal problems which are persistent or recurring that are provoked or exacerbated by the effects of alcohol. Consumption of alcohol provokes abandoning or reducing important social activities. There is a recurrent use of alcohol in situations in which there is a physical risk. For example, if a patient drives under the influence or uses a machine or exposes himself to a situation where being under the influence of alcohol could be risky. Continues using alcohol despite knowing that there is a physical or psychological problem which is persistent or recurring, probably caused or exacerbated by alcohol. Maybe you have seen that in patients that persist using alcohol despite having liver test altered. Tolerance defined by some of the following facts: need to use larger amounts of alcohols to achieve intoxication or desired effect. Reduced impact after using the same amount of alcohol. Abstinence expressed by some of the following facts, such as presence of the characteristic withdrawal syndrome of alcohol, alcohol is used or some other substance, benzodiazepine, to relieve or alleviate the effects of withdrawal. To close, some challenges proposed in the classifications of alcohol use disorders in general. The inclusion of biomarkers was considered from DSM-4 to DSM-5 in the light of current evidence that had to be discarded. So far, there are no biomarkers that can facilitate the diagnosis, although some are working on that and it's not being discarded completely. There are problems related with alcohol that will not necessarily fall in this classification. For example, they would fall in not otherwise specified. There are some that are very problematic and should be individually classified, such as alcohol binging. This is something we see in younger people. ICD-10 has these episodes of noxious use or pattern of noxious use. It could be classified as something that has less intensity, so that the patients are not left out. I don't know if I made myself clear. And also try the validity of the new criteria of DSM-5, although the study team says since DSM-4 validity has been approved that everything came from that classification, there shouldn't be problems about it. Other challenges. Well, conclusion. I included this famous painting by Peter Bruegel. This is the biblical account on how God tries to punish man because greed or audacity to build this big tower, allowing him to reach heaven. So languages are confused. If we can see this in a different way, maybe this confusion can be an opportunity to be able to create a common language, learn from each other, and pull criteria that can help us get closer to our brethren. All right, thank you very much.
Muchas gracias, doctor Herrera. Muy
Thank you very much, Dr. Herrera.
la presentación mostrando la
Very enlightening,
diferencia
showing the
de las distintas
differences between the different classifications from AUD.
mencionarles dos cosas.
I have two things to mention. It's the first time we'll be having for the first time a talk on a new topic by Dr. Bersone, hepatologist, gastroenterology professor as well, and head of the gastroenterology and hepatology department at the Hospital of Rosario in Argentina. And his talk will be on the assessment and management of alcohol abstinence. The second point I'd like to show is that after this presentation, we'll have a brief recess, and we'll be after which we'll reconvene at 3:40 p.m. Chilean time to continue with this talks. Dr. Bersone, then the floor is yours. Good afternoon. Thank you for having me today. To Luis Diaz and Juan Pablo Arab, it's an honor to be here and to go over this topic. We will begin in terms of the amount of alcohol, in terms of what is allowed in the legal framework. Here we have a classification of drinks a day measured in ounces. You can see that the purer it is, the less ounces you can consume, as you can see on the right. If it's whiskey, if it's hard liquor, it's far stronger than in the case of alcohol. Now, Ramon Letelier gave me a couple of slides, such as this one, where he presented AASLD. Since the liver is basically the focus of what's going on with alcoholism, patients who have more fibrosis have a higher mortality rate. Now, same thing can be said, on the other hand, of people with abstinence. Abstinence can lead to significant reduction in long-term mortality. Something very similar occurs with relapses after alcoholic hepatitis. As you can see, more than half of the patients relapsed. Some patients relapsed years after an episode. And moderate and rare relapse has a negative impact on survival. So mortality in conclusion is higher with them. Now, where does a physician come in? Well, there's a spectrum. We have patients who consume substances or alcohol sporadically, others who do it intermediately, and others who have more or less dependent. There are patients who are in an at-risk phase who aren't still dependent per se, but that's when the physician has to do as much as possible for discussion, for psychological treatment, among others. How should you focalize this? Well, what patients will be needing abstinence treatment? How do you qualify it? How do you qualify alcoholism? How will you be treating this with drugs or with sessions? So if you add the hepatological element, a lot of these patients will be requiring very aggressive nutrition treatment. They know that alcohol has basically empty calories. So we know that there's complications from varices, bleeding, and so forth. Now, here we have to look at the craving, which is the compulsion to consume, control, and consequence. By qualifying alcohol use disorders, you can characterize it as acute intoxication, risky use of alcohol, which finally leads to dependence. You know that there is a standard manual, the DSM-5, which qualifies 12 points, with 12 points, so you can tick off and see the severity where the patient lies in, if they're recurrent, if their consumption is only in at-risk situations, if it's continuous, how their tolerance is, if they've had withdrawal syndromes, if they drink alcohol in greater amounts during certain periods of his life, if you've got a persistent need to drink, if the patient spends a lot of time recovering off of alcohol, if alcohol has left them to abandon their job or their social circles, and if they have alcohol-related anxiety. This would be the 3 C's: craving, control consequences. Diagnosis would be 2 or more of those prior criteria in the 12 months. And 2 or 3 of these would be considered mild, 4 or 5 of them ticked off moderate, and 6 or more would be considered severe. And that's where you really need to step in. Psychological treatment is one of the pillars in the management of this patient. I had the chance to participate together with Dr. Arab and another large group of hepatologists. We had these Aleh guidelines where we looked over this topic exhaustively, and we could see that these patients require interviews at their visits to see what situation they're in, the patient, I mean, to see if you can implement cognitive therapies, motivational enhancement therapy, CBT, and participation in AA meetings, for example. Here you ask about the amount they ingest. It's essential to see if the patient is willing to suspend their use of alcohol. Motivation is key in these visits. To advise them about the risks with excessive use, to give them options for recovery and for follow-up, and if they put together and how to put together proper follow-up. This cognitive behavioral therapy is key because it's based on patients getting better. They can get better at something at home, which they learned in therapy. So this can have a snowball effect or an indirect effect in different problems. So this motivational enhancement therapy aims to help patients by working on their resistances. Their resistances to dropping the habit. And with CBT, you can find out the triggers that would lead the patient to consume high amounts of alcohol. There are studies that clearly showed how patients who are motivated, how these end up having a better response when it comes to the work they need to do. Now, with what drugs do we begin to treat these patients? And this is quite a hot topic, quite broad. You could split them up by the FDA approved and not approved ones, agents. But this all has to be modulated based on your access, the ones you have at hand and so forth. We'll be trying to give you an approach linked mainly with the drugs of choice and then second line treatment. But as hepatologists, we have to understand the status of the liver. Decompensated cirrhosis is different from a compensated one, because if they're in alcoholic hepatitis and they've got cirrhosis or they've got ascites, the situation differs from one of a patient having compensated cirrhosis. Here you can see on the left what a compensated cirrhosis could very well look like. Their child score luminal is good. their liver function tests are good, their LFTs. And we can see on the right what happens when it's not compensated. So we have child A, where most of the trials are focused on. And by that, I mean studies on drugs, when they have good bilirubin. Now, if we have predictive factors, child B and C, even for hepatotoxicity, cholestasia, hypoalbuminemia, polypharmacy, all of that contributes towards the patient developing more hepatotoxicity or liver toxicity. Let's look more on the agents that are approved by FDA. Now, Naltrexone is almost there. It blocks opioid receptors. You know that alcohol stimulates dopamine levels in the nucleus accumbens mainly, and that endorphins increases synthesis, and on the other hand, it lowers GABA. So naltrexone will be blocking specifically in those situations because an opioid blocker and that inhibition of GABA and the release of all of those endogenous opioids, which would justify the addictions from these patients. So naltrexone, what it attenuates mainly, it's even been showed in the case of cocaine, the manifestation of euphoria in alcohol, the gratifying sensation that alcohol produces. You can see it's very important to take into account to have caution with certain situations. We can't give this with other opioids. Now, what happened to lung function tests? Because there's been some restrictive factors in the lung associated with this drug, but it's tolerated quite well, and based on what is published up till now, there's no hepatotoxicity in sight, and the liver tolerates this situation quite well. The other first line agent would be a camprosate, a glutamate, which also levels GABA, levels out. It's a glutamate antagonist. However, it cannot be used if creatinine clearance is less than 30 mils a minute, and it has to be done with an abstinent patient. So you need renal tests. Disulfiram, it's been out since the 60s. That's what's used at the end if you've got nothing else. It is quite disagreeable in terms of the manifestations. The vasodilation syndrome, of hypotension, of passing out, a very, very unpleasant sensation when drinking alcohol on disulfiram. There's hepatotoxicity documented, even severe cases. There are other drugs that aren't FDA approved, but which tend to be very useful in clinical practice. Baclofen, it's the only drug that has a trial in cirrhotic patients from child A. It also has an effect of GABA agonistic, which can be given in some renal patients. It's better than acamprosate, at least in the renal arena. It can be used in cirrhotic patients. You can see that the relapse period was far lower in patients who are on baclofen, where they started with 5 to 10 milligrams a day. We had to try to attain a 20 milligram dose. So those beneficial effects, patients who are highly anxious, in withdrawal, in cigarette smoking, and gabapentin, which also levels out GABA and which inhibits the release of neurotransmitters, also has very significant effects, such as an anxiolytic effect, such as lowering cravings. We can see that all of these drugs will have an impact on patients who have some renal disorder with different clearance to what they should be. You have to regulate the dose. We have to test the renal function, 600 milligrams 3 times a day with the objective dose, but has to be adjusted with the creatinine dose. They're taking a gabapentin. You have to increase the dosage based on tolerance. So this can lead to cytochrome induction, enzyme induction, which can lead to alcohol having a greater tolerance. Topiramate is also used for other situations, such as dizziness, headaches. It also increases GABA activity, despite the fact that all these compounds can lead to confusion, dizziness. Topiramate has to be seen from the renal point of view because there's a clearance, a window. And if there's an excess, you'll have to reduce the dose by at least 50%. And finally, how to monitor patients in treatment. They need very close follow-up. This is something that the patient will have to undertake. So if the patient cheats, it'll be like going back on the cycle of alcoholism, the guilt and shame and so forth. So the therapist has to be very close to provide containment in those situations, to see if the patient is cheating, so to speak, or not making good on their compliance. So we've got a lot of laboratory elements so you can control it, from metabolites of alcohol in urine and blood, or other tests that can fish out alcoholism. You have to measure renal function clearly. A lot of these compounds tolerate a determined creatinine clearance, and below 30 of creatinine clearance. Some have it below 30, 70, 80, but there can be a reduction that could lead to you reducing doses. We have to see if the patient is compliant. Are they making good on their abstinence? If there's any parallel alcohol consumption, to get the idea of progression and to get a baseline to see how the patient was improving in terms of dosage reduction. Generally, it's recommended to taper off and when it comes to alcohol consumption. It's very important to document the current pattern of ingestion to see how the patient progressed. I'll be wrapping up. Among the conclusions, first of all, we need to come to a correct diagnosis of addiction, alcohol use disorder. See how much they're drinking. From those 12 items, as I'd mentioned, if they make good on 3, 6, 8, that'll determine whether it's mild, moderate, or severe. Second, evaluate the possibility of implementing psychological treatment, which is clear for creating a framework on the type of patient you're dealing with. We also have to look at liver tests, support and understand what degree of deficit or what degree of liver function they maintain. It's difficult in child C than managing a child A patient. We'll have to be dealing with a lot more obstacles. Fourth, selecting the correct medication for treatment based on hepatic renal tolerance and availability. In Argentina, we don't have a camprosate because we use Baclofen more and naltrexone. There's 3 FDA approved naltrexone correction and camprosate. Those came on their last guidelines as preferential. Naltrexone and camprosate would be indicated for patients who have moderate to severe alcoholism, and that's where we've seen the best results. If none of them adapt with those, then you should consider Disulfiram. And if they're all 3 contraindicated, then, well, we should try with Baclofen, Gabapentin, Quetiapine, Nalmefene. Could be. It's appeared in guidelines. Opioid inhibitor levels out GABA as naltrexone. So it could be used. And here are some slides by Dr. Batalier that I'm thankful for. Very good to wrap up. Where the hepatologist at the center of this situation will be handling the access of the hepatotoxicity risk of tolerance. The patient, if you have to treat some alcoholic hepatitis, identify the situation, the underlying situation when it comes to the AUD. So it's a pleasure to present, and thank you very much.
Hola, buenas tardes y bienvenidos de vuelta a todos para esta segunda parte de nuestra jornada.
For this second part of this training for gastroenterologists and hepatologists. The presentations have been incredible. Now we'll go to the second half, which is much more practical. We're going to have presentation on how to do brief interventions, drug therapy, what drugs approved or not by the FDA. We will see how to use them. And then we will speak about drug therapy.
Así que para partir, la
And
primera...
so in order to start, the first presentation is about brief interventions and advisory techniques by Dr. Gerald Winter. He's associate professor from the Department of Psychiatry, Surgery, and Neurology from the University of Michigan, United States. He was co-founder of several transplant clinic, pathology, epilepsy, and treating patients with different diseases in a multidisciplinary fashion. He's a leader in his field. It is an honor to have him.
Hi, everyone. I'm Scott Winder, psychiatrist at the University of Michigan. I'll be speaking today about brief interventions and counseling techniques in alcohol use disorder as relevant to hepatologists and gastroenterologists. I don't have any disclosures. What I hope to accomplish today is to show some of the barriers to alcohol interventions within hepatology and increase your overall openness and curiosity about the psychological aspects of patients who you work with who drink. I aim to provide you with practical insights and tools to improve how you approach and understand alcohol problems in your practice, and to promote the idea that you need to partner with mental health colleagues to fully meet alcohol challenges within hepatology. Let's get a glimpse of some of the alcohol data. Alcohol causes 1 in 20 deaths globally and is now the leading cause for liver transplant in many countries. Alcohol accounts for 27% of cirrhosis-related deaths and 30% of those related to HCC. Alcohol problems tend to be chronic, relapsing, and comorbid with other substance use and mental health problems. Many patients tend to have low access to specialized alcohol treatment, and liver patients often misrepresent their drinking, particularly in the transplant environment. Alcohol challenges in hepatology are not small, and those of us working in this space in hepatology and transplant can feel like this climber ascending a sheer surface more or less on our own at times. Alcohol issues in hepatology can be confusing for patients. They get a lot of different and conflicting information from all the specialists that they see. And alcohol issues are also confusing for us clinicians, since patients and their medical records may not always be consistent or coherent. There are dangerous gaps between hepatology and psychiatry. Hepatologists may not understand alcohol and mental health problems very well, and psychiatrists often do not understand liver disease or transplant. We may not ever really collaborate one with another. Alcohol patients can then fall into some deep gaps where they don't access quality care by clinicians who understand their whole disease and who will follow up on it. We must construct bridges across our specialties. We can use any number of words to describe the training and relationships that we need to better treat alcohol problems in liver disease. We just talked about building bridges across specialties, and we must also be able to bridge and connect different points of view about our patients. Views of alcohol patients are often in opposition, so-called dialectics. For example, alcohol patients can be reduced to their liver function, lab values, and addictive behavior, but they can also be evaluated holistically at the level of their minds, health, and personhood. And we need both perspectives and all the gradients in between to do this work well. Our perceptions of disease matter. Medical and surgical aspects of gastroenterology, hepatology, and liver transplant can sometimes appear to us as more real or more fundamental and important than mental health. The parts of alcohol that hepatologists might prefer to focus on and naturally focus on are its metabolism, pharmacology, and toxicity. The reality is, though, that there are crucial behavioral and psychological aspects to alcohol-related liver disease that are inseparable from the hepatotoxicity. Surgeons performing a particular operation often save a patient's life and can be quite sure that their efforts were what saved the patient. But this is not the case in alcohol use disorder. We will not save an alcohol patient in this way, and that's okay. We need to adjust our expectations accordingly. One last thing about this. The surgeon and the anesthesiologist have all the control in the operating room. The patient is unconscious and completely reliant on them. But during alcohol conversations like the ones we are talking about today, patients are in control of what they think and what they do and what they say. We cannot approach alcohol interventions like surgeries, like something we do to patients. Not only will we be ineffective, but we will also burn out in frustration. So in order to intervene and counsel alcohol patients, we need interprofessional relationships, decreased stigma, additional clinical skills, quality teamwork, and we must make this all a clinical priority. Let's focus a moment on stigma. Stigma, defined, is a mark of disgrace associated with a particular circumstance, quality, or person, a mark of shame or discredit, a stain. Said another way, it is a biased or unfair view of a person or situation. Stigma will unfavorably affect how we evaluate and treat our alcohol patients. Sometimes a good antidote to stigma is sympathy. So for a moment, let's shift our view away from patients who drink to us. These are data about the risks of hazardous drinking in physicians. While our rates of alcohol dependency may be lower or similar to the general population, our hazardous or binge type drinking is often measured above base population rates, as you can see in these statistics. 10 to 12% of US physicians will develop a substance use disorder in their careers. In a cohort of 904 addicted physicians followed over 6 years, 19% failed substance use disorder treatment. At 5-year follow-up, about 1 in 10 had their licenses revoked. Again, by acknowledging our own risks as people and physicians, we can feel less stigma and blame and judgment towards patients and more sympathy for them. And that's an ingredient we need to be able to counsel them. Like any toolbox, this toolbox will be personalized as to what's inside, but I'll share some ideas for what an alcohol toolbox for liver clinicians might contain. First, we need to remind ourselves what medical tools really are. Yes, they are the physical objects used in operating rooms and during procedures, and medical tools are also the words, ideas, vocal tone, facial expressions, relationships, and attitudes that we have with patients. These are tools we will need to acquire and practice with in order to do our work well. We must remember, of course, that many skills can seem very simple on the surface when they are actually quite difficult to master and require lots of practice. For example, I may be able to sing in the shower and sound pretty good, but that's a long way from a professional artist giving a concert. I can lift weight regularly in the gym and still be nowhere near a professional skill and strength. I can talk with friends and ask thoughtful questions of my patients, but this does not mean I know how to be a journalist. We can trick ourselves into thinking that we're better than we are. We don't want to fall into this trap. Regarding counseling alcohol patients, I've learned this firsthand. It seems simple and easy on the surface, but it requires diligent practice and thoughtful progress to become capable and effective. Foundational to effective counseling requires a therapeutic alliance, which includes compassion. We want to rapidly and authentically connect with and care about patients, whether they are drinking or sober, honest or deceptive, whether we like them or not. Patients and families need to understand what we do with the confidential mental health and addiction information that we get from them. They should understand our clinical roles in their care, and if we are on a transplant selection committee. We should be clear about our expectations during the interview and during future care encounters. Patients and families should easily grasp the long-term nature of our alliance, which extends years into the future in some cases. Next, let's say something about the actual techniques that we might use to speak effectively and therapeutically with patients about their drinking. Alcohol discussions in hepatology require skilled, compassionate, neutral, and inquisitive interviewing. Again, it's difficult to do this well since we must balance the need for a wide and efficient view of a person with the need for careful focus and detail. Motivational interviewing is a crucial relational and communication skill set to partner with our patients about lifestyle changes, including reducing and stopping drinking. This approach is patient-centered rather than directive. We physicians tend to be more directive. We may need to probe for initial terminology that patients and families can actually accept and use to discuss their drinking, even if we think that this label might be inadequate. If we just call their drinking addiction, patients may turn off and tune out. We may need to use softer terms like habit or health behavior to really connect with patients and their families about drinking. Selecting the right word, selecting the right tool for an effective patient discussion is deceptively difficult. The way we approach patients is a layered and careful approach as defined by motivational interviewing technique and philosophy. Engaging is where we form a working relationship with the patient. Focusing involves understanding what the patient's agenda is for their change, and it may be different than ours. The phase of evoking is key. It involves eliciting a patient's own reasons for change, helping them get into touch with their own motivation rather than insisting that they mirror our motivation. Finally, planning occurs when a patient's motivation reaches a point that allows them to prepare for action. Let's drill down a bit more on how we communicate with liver patients about alcohol. Motivational interviewing contains a helpful acronym, OARS, about the questions and statements we use to assist patients in exploring how they might change their drinking. O stands for open-ended questions. Think of these as open doors for patients to explore their thoughts and circumstances. These questions should not be able to be answered with a simple yes or no. Here's an example. Tell me about your risk of substance use coming back. Next, A stands for affirmations. This is accentuating the positive. We must do this authentically to avoid appearing condescending. Substance use can be a magnet for negative emotion from others, making this extremely important. We will continually be surprised at how important this technique of positively regarding our patients really is. Here's an example. You've made some recent admirable changes. R stands for reflections. Reflections communicate to patients that we're hearing them, encourages them to explore what they think and feel, allows them to hear their own thoughts and story in a different way, and clarify when needed. An example would be, it sounds like you've been thinking a lot about this lately. S is for summarizing. Summaries collate all the data that patients give us. It is important to remember that we may be able to see obvious connections and other data that patients cannot yet perceive, and summaries help them see those new connections. For example, it seems to me that your liver disease came on quite suddenly, negatively affected your mood and relationships, and brought out some desperate feelings. All this kept you drinking, just to try and manage in the middle of this big storm of events. Analogy and metaphor are wonderful tools to facilitate alcohol discussions and communicate key information about prevention, treatment, and risk. They allow us to step outside of the alcohol issue, which naturally makes many people feel really defensive. They allow us to tap into knowledge and skill and insight that patients already have and use. For example, we can liken alcohol treatment to a seatbelt and an alcohol relapse to a traffic accident. Most people already consistently wear a seatbelt. They will tell you that they do this, and they skillfully defend their rationale in doing so. So using this metaphor allows patients to quickly apply what they already do to prevent traffic accidents to the types of measures they must take over time to prevent an alcohol relapse. Yes, a car crash might be an unlikely event, but it is dangerous enough that we all want to prevent it. So it should be with alcohol relapses in liver disease. Analogy and metaphor are efficient ways to transfer knowledge and build insight. Let's move on to screening questions and questionnaires. There are several of these. The Audit C is one screening tool for the detection of alcohol use disorder. It has 3 questions which appear here in the graphic, and the scoring appears below. You can see the sensitivity and specificity of how this test performs in a primary care population using scoring thresholds of 3 for women and 4 for men. Toxicology is another important tool in a hepatologist alcohol toolbox as helpful verification of a patient's self-reported use. Urinary ethylglucuronide and ethyl sulfate are 2 highly correlated minor ethanol metabolites detectable during a 3 to 7 day detection window. Their performance for detecting and excluding 3-day and 7-day drinking appears below. Serum phosphatidylethanol, or PEth, is a lipid species and marker of alcohol exposure that persists in the bloodstream for up to a month. Some studies show that it reaches different levels in different sexes and in different drinking patterns. The lower graph shows how quantitative PEth values correlate with audit scores, meaning the higher the number on the lab result, the higher likelihood of moderate to severe drinking and related dysfunction. A few important points about toxicology. These tools are not to be used with a cynical or gotcha mindset. A positive screen does not make an addiction diagnosis. A negative result doesn't necessarily mean that a patient is not using, and our findings should always be accompanied by thoughtful analysis and compassionate clinical interviews. Our clinical examinations and lab testing of a patient can be supported by seeking other mental health and addiction information from the prescription drug monitoring programs in our area, outside records and past entries in the electronic medical record from other professionals who interviewed and interacted with the patient, family and friends, psychiatric providers caring for the patient, and testimonials from the patient's recovery community supports. All of this requires that we monitor and preserve patient confidentiality. To boost our sympathy towards our patients who drink, we might consider more active listening to them when we interview them in their hospital room or in clinic. Perhaps we attend an open 12-step meeting like Alcoholics Anonymous to learn and feel more about this disease, feel it for ourselves. Art and media can be powerful ways to deepen our sense of addiction, what it does to people, to help us be more compassionate and patient and thoughtful. Here are several books and movies to consider. In the end, hepatologists will refer patients for further treatment, which can range from outpatient options like 12-step recovery groups, individual therapy, and medication management, to more rigorous options like intensive outpatient or partial hospitalization, all the way to inpatient detoxification and rehab. Having interprofessional partnerships and a working alcohol toolbox will help hepatologists select the appropriate level of treatment, a topic that we don't have time to fully explore in detail today. However, when alcohol care is fully integrated into hepatology, meaning psychiatric providers are treating liver patients alongside hepatology, then some of these options might be available within a single liver clinic or within the hospital service. Many liver patients implicitly trust their liver clinicians more than mental health professionals, so your ability to counsel patients is an important step toward getting them the treatment that they need for their liver. Finally, before we end, a plug for interprofessional alcohol practice within hepatology. Talking about teamwork to medical audiences is about as exciting as talking about hand washing. We all know the importance of hand washing, what an elementary and foundational principle it is, and yet I'm sure you all are also aware how poorly we all tend to do it. Teamwork is the same. It's an obvious and easy principle to understand, but it is so difficult to consistently implement it. Teamwork within any individual team is important, certainly, and interprofessional teamwork, working across disciplines and integrating various perspectives and clinical skill sets, is particularly important and difficult when we consider treating alcohol problems in hepatology. Interprofessional teamwork is an established idea supported by decades of literature in medicine and other fields. It impacts patient safety and care delivery throughout the health system. It has also been shown to be a factor in patient satisfaction, length of stay, and mortality. It affects clinicians as well in terms of our retention, morale, and sick leave. Hepatology is already calling for such multidisciplinary and interprofessional care for ALD patients. Here's another call for interprofessional practice when it comes to acute alcohol-associated hepatitis. We won't have time to discuss the specifics of how interprofessional alcohol care can be built step by step and then sustained over time within hepatology. But this article and those that it cites goes into much more detail. Thank you so much.
Muchas gracias, Dr. Winder.
Thank you very much, Dr. Winder, for your wonderful presentation. I'd like to introduce Dr. Rodrigo Santis, psychiatrist, specialist in addictions from the Autonomous University of Barcelona, works at King's College at the University of London, and he's a clinical researcher with the addiction unit at the Catholic University of Chile. His talk will be on FDA-approved medication for AUD, Disulfiram, acamprosate, and naltrexone. The floor is yours, Dr. Santis. I'd like to thank Aleh for having me and to present. This topic deals with FDA-approved medication for alcohol use disorder, among which we can find disulfiram, acamprosate, and naltrexone. Here's some background. AUD treatment implies pharmacological and psychosocial interventions. Overall, a low number of patients actually accesses treatment, about 10%. And the drugs that would be potentially useful aren't that used by clinicians, at least in the first phase of treatment. The drugs that exist have proven efficacy. However, when comparing efficacy with other agents used to treat other types of substance use disorders, its efficacy is somewhat reduced. When performing pharmacological approach for AUD, there's three potential goals. The first would be management of withdrawal syndromes. Second would be preventing relapses. The idea being that the patient can maintain their abstinence. And finally, management of psychiatric comorbidity, mood disorder, anxiety disorder, etc. What would be the goal of pharmacological relapse prevention? Well, it's to help for the patient to maintain and prolong abstinence, to decrease cravings, which could lead to relapse. And if they do have a relapse, to avoid that it becomes excessive, more than 5 standard drinks. What will be the FDA-approved drugs which are proven effective? The oldest would be Disulfiram, approved in 1951, available in Chile. Naltrexone, which was available orally in 94, injectable 2006. Sadly, from 2021 on, you cannot find naltrexone, but it is available in other countries. Compensated, FDA approved in 2004, not available in Chile, but is a good alternative for pharmacological treatment for relapse. Going on to Disulfiram, the first one, its mechanism of action is to perform irreversible antagonism of the liver enzyme aldehyde dehydrogenase, particularly the type 2 isoenzyme, which leads to an increase of systemic acetaldehyde, which is the substance which creates the symptoms that we'll be seeing shortly. Disulfiram also has been known recently to inhibit a CNS transmitter, dopamine beta hydroxylase. And this leads to an increase in dopamine and improvement in the mesolimbic dopaminergic circuit, which will lead to a reduction in desire in cravings. Now, in this alcohol disulfiram reaction, well, it's a dose-dependent reaction, but it'll lead to headache, sweating, redness, flushing, dizziness, nausea, and/or vomiting, low blood pressure, tachycardia. This would be the most typical. This could become severe with lack of consciousness, could even lead to coma and even death if the dose of alcohol is quite large. In terms of the clinical use of disulfiram, this has to begin with explicit consent from the patient who has the intent of becoming abstinent. So here we're dealing with a subgroup of patients with a particular motivation to stop. Basically because the patient cannot continue to expose themselves to risks when it comes to the reaction of disulfiram with alcohol, as mentioned. Supervised administration by a spouse, for example, it's better for adherence or compliance. Before beginning on disulfiram, you have to perform blood tests, renal liver tests, EKG, pregnancy tests if it's a woman, at least 48 hours abstinence, so that the patient will, so you won't have a patient taking a dose after having recently consumed alcohol. Daily dose is about 250 milligrams taken orally. In patients with a BMI which is high, it could go all the way up to 500. Same with low weight. You could use a lower dosage such as 125. We need periodical follow-up on the liver tests 2 weeks after beginning. Your first liver test should be gotten to see that to rule out any damage. Then you do monthly for the first 6 months, and then every 3 months. What would be the adverse effects of disulfiram when not taking alcohol? Not many. Sometimes some have reported a rash, GI upset, drowsiness, headache, tremor, metallic taste, slight increase in transaminases, which can be present in 25% of the cases, which usually doesn't need to modification of the dosage. Now, some things that can happen, not as frequent, which would lead you to take them off or reduce the dose: delirium, depression, psychotic episodes, increase in transaminases more than 3 times the normal rate, which can happen in 4% of the patients on disulfiram, and liver failure, which can be to 0.3 to 1 for every 10,000 cases. We can even see some optic neuritis and peripheral neuropathy, which would all lead you to take them off the drug. It's important to explain to the patient that when the patient goes off disulfiram due to their own motivation, for example, or an initiative, the inhibition of the aldehyde dehydrogenase can last up to 2 weeks. So you have the enzyme turnover in the liver. So the patients have to know that if they are exposed prematurely to alcohol, they can still display the effects up to 2 weeks after stopping taking the drug. Secondly, we've got naltrexone. It's an antagonist of the mu opiate receptor, also for kappa and lambda, but mu would be the mesolimbic system, dopaminergic system. It attenuates the release of dopamine. Alcohol, when stimulating this mesolimbic system, it leads to a massive release of dopamine, and that's what naltrexone attenuates. The net effect is that there's an increase of days on abstinence. There's a reduction of the reinforcing effect of alcohol, so it leads to less enjoyment of alcohol. The cravings go down, and therefore the amount of ingested alcohol. In terms of clinical use, well, we need prior workup, overall workup, liver tests, any drug tests in the urine to rule out opiate consumption, since it can trigger a withdrawal syndrome if they're taking it. To get a pregnancy test, it's also necessary for the patient be off alcohol for at least 3 to 7 days. There's 3 forms or formulations. One is oral, a 50 milligram pill a day, the most used one. it leads to the greatest side effects. So often patients, when going off the drug, it's because of this. Now, in terms of the injectable formulation, decreases it impedes the adverse symptoms and it improves compliance. And these would be intramuscular every 4 weeks. And there's just for pro-renata or just as needed, PRN, which would be 50 milligrams when used pro-renata 2 to 3 hours before any ingestion is envisioned. So we still need studies that would talk about the benefits of PRN use. Now, its use has been approved for 3 months, but there's evidence that it can be safely extended to 6 to 12 months. Patient education is necessary in terms of opiates being contraindicated while taking naltrexone. Periodic follow-up is performed, liver tests after a month, then after the 3rd month, and then every 6 months. What would be the side effects? And these are temporary: nausea, vomiting, headache, dizziness, fatigue, anxiety, drowsiness. Now, this could lead to a lack of compliance. Now, the least frequent side effects, which would lead you to take them off the drug, would be diarrhea, constipation, cramps, chest pain, joint and muscle pain, skin rash, insomnia, dry mouth, anorexia, sweating, depression, liver toxicity, among others. All of these would lead you to take them off the drug. Number 3, acamprosate. It's an analog of a neuromodulator known as taurine, which regulates the equilibrium between the excitatory system, which would be glutamate, and agonist, which would be GABA. When they have an AUD, the balance between excitatory and inhibitory systems, it favors the excitatory one. So with glutamate antagonism, you'll block the MDMA receptor. And with GABA, since it's a GABA agonist, it will switch things towards inhibition. Now, the clinical effect that patient observes, you can see a reduction in late withdrawal symptoms. It can take 2 to 3 months to normalize. And that process is accelerated due to acamprosate, which decreases mood instability, irritability, insomnia. Acetylhomotaurine, calcium bisacetylhomotaurine is the name. Campril is the brand name. 333 milligrams are taken. We need general workup and prior renal workup. And this is contraindicated in case of severe kidney failure. So look at the creatinine. The dose will depend on the patient's weight. If they're over 60 kilos for the first 3 days, you start off with 1 pill 3 times a day, then and when seeing tolerance, you go up to 2 pills 3 times a day. Morning, lunch, night. If they're under 60 kilos of weight, the first 3 days, you give them a pill every 12 hours, and after 2 pills in the morning, 1 in the afternoon, and another at night. You begin this 5 to 7 days after abstinence of alcohol, the effect will be seen after 1 week with the dosage, the complete dosage, and the treatment lasts about a year. Now, it mainly increases the days of complete abstinence. What will be the adverse effects? Overall, it's well tolerated. We have some GI upset, diarrhea, which is fleeting, but can lead to a lack of compliance. You could try to lower the dose to try to counter out that effect and then go get them back up again. The least frequent side effects that would lead you to take someone off the drug would be suicidal ideation, headache, flatulence, nausea, decrease in libido, insomnia, anxiety, weakness, dizziness, and itching. When presenting these symptoms or signs, they'll ask for it to be taken off. In terms of the take-home points, we can see that medication is effective for preventing relapse, since it prolongs abstinence. It reduces excess consumption, and they reduce the craving. We need to be careful on the lookout for liver toxicity with disulfiram and naltrexone, and care with renal function when using acamprosate. Now, the use of these medications, apart from being safe, should be integrated with psychosocial interventions in order to obtain the best results from relapse prevention in the context of AUD. Thank you very much. Thank you very much, Dr. Santis, for your presentation. Up next, we'll have part 2 of this talk would be non-approved FDA drugs for AUD. So here we're looking at Baclofen, Gabapentin, and Topiramate. This talk will be given by Dr. Lorenzo Leggio, physician, scientist, senior researcher from the NIH, scientific director and head of translational medicine from the National Institute on Drug Abuse in the United States, and he's collaborated with us frequently. So I'd like to thank you, Dr. Leggio, for the talk.
Good afternoon, everybody. And so what I'm going to do is to talk about FDA non-approved medications to treat alcohol use disorder, with a focus on a few examples, which are Baclofen, Gabapentin, and Topiramate. And first of all, I'd like to thank Dr. Abril and all the organizers for inviting me to present today at this very exciting crash course. So in general, as you know from previous speakers, treatments for addiction, in particular for alcohol use disorder, included both the behavior treatments and the pharmacological treatments. And within the pharmacological treatments for alcohol use disorder, as you know from the previous speaker, from Dr. Rodrigo Santis, we have 3 medications approved, which are acamprosate, disulfiram, and naltrexone. However, over the years, we have actually increased our understanding of the mechanism, of the neurobiology mechanism that is related to addiction. And this gain in knowledge has been very important because has been actually critical to help us to identify new targets and develop new treatments for individuals living with alcohol use disorder. And in fact, with that in mind, in the past couple of decades, there have been actually quite a few medications, including those that I'm going to talk today, that have been tested as a potential new treatments for alcohol use disorder. And these medications include the Baclofen, Gabapentin, ondansetron, Topiramate, varenicline, and there are a few more actually not included in this table. But what is very important to emphasize is that as my title also alludes to, these are not approved by the FDA for the treatment of alcohol use disorder. These medications are approved for other indications. They have been repurposed via research randomized clinical trials in alcohol use disorder, and they can be used off-label pending on agreement between the physician and the patient. And one of the examples I'm going to make today is Baclofen. Baclofen is a GABA-B receptor agonist. It's a medication approved for muscle spasticity, but in the past actually years, there have been an increasing number of preclinical data summarized, for example, in this review, and also of human clinical data summarized in this second review that suggests that the Baclofen may be an effective medication to treat alcohol use disorder. And relevant to this meeting today for gastroenterologists and hepatologists, a few years ago when I was working in Italy before moving to the United States, we performed a randomized clinical trial with Baclofen where we specifically tested Baclofen in patients with alcohol dependence and liver cirrhosis. And the rationale to do that is because Baclofen has a very little liver metabolism. It's primarily excreted by the kidneys, and there were no actually known safety concerns from a hepatology standpoint in terms of giving Baclofen to these patients. What we found in this clinical trial was that compared to placebo, Baclofen was significantly more effective in promoting total alcohol abstinence. And among those patients who were not able to maintain abstinence, still Baclofen was more effective in increasing cumulative abstinence days. So people were more likely to be abstinent under Baclofen compared to placebo. We also found an improvement in the liver tests, such as ALT, bilirubin, INR, and albumin. This is not meant to be that the Baclofen per se is improving liver function, but it's clearly relative to the abstinence. So meaning that the Baclofen is helping patients compared to placebo to maintain abstinence, and abstinence from alcohol in turn is leading to an improvement in the liver test. But this is also important because it does also suggest and indicates that helping patients to reach and maintain abstinence is always critical in this field, even in those patients with more advanced liver disease, such as in this study where we enroll patients with type 2 A, B, or C cirrhosis. And in fact, regarding the severity of the liver damage, we also conducted secondary analysis specifically focusing on a subgroup of patients with alcohol dependence, liver cirrhosis, and hepatitis C virus. And we found again that the Baclofen did promote alcohol abstinence, even if the sample size was smaller. So suggesting that in fact the Baclofen may be particularly indicated to treat alcohol use disorder in those patients with more advanced liver damage. And consistent with this hypothesis, there are two more studies that actually suggested the same. Specifically, one study was conducted in the United States and one study was conducted in Sydney, Australia, and the results were actually different. So the US study did not show a difference between Baclofen and placebo, but of note, this was a VA study done in people with chronic hepatitis C, but with relatively low level of drinking. So suggesting that in fact in these patients with a lower severity of alcohol dependence, Baclofen was not superior compared to placebo. By contrast, in the Australian study, they enrolled the patients with more severe alcohol dependence, and they did find that the Baclofen was more effective compared to placebo in actually improving alcohol-related outcomes in the patients with alcohol dependence and liver disease. So this negative study and this positive study, which is consistent with our 2007 Lancet randomized clinical trial, together suggest that the baclofen may be helpful in patients with alcohol use disorder and liver disease, but maybe this effect is limited to those patients with a higher severity of dependence. Case in point, a few months ago, Jesse Garbut and colleagues published this other randomized clinical trial, for which we also wrote an editorial. And this was not in patients with alcohol-associated liver disease. But nonetheless, it's important because here, in this trial done in the United States at UNC, they actually use drinking levels higher compared to previous clinical trials. And they found that the baclofen, specifically the higher dose of baclofen, was significantly more effective in decreasing heavy drinking days and in increasing abstinent days. But of note, they also found an important sex by medication interaction, so suggesting once again that the effect of baclofen may be limited to some specific subgroup of patients. And as we emphasize in our editorial, this is really important to keep in mind. We are not going ever to really find a medication for alcohol use disorder that will work for any patient. So the data with baclofen suggesting that gender does play a role, is suggesting that the baclofen may work only for some patients, for example, those with more advanced liver disease, those with higher severity of dependence. All this information is actually important because it does emphasize that it's very important when we think about medication development for alcohol use disorder and for addiction in general to think about personalized treatment. So thinking about matching the patient with the medication, thinking about who is the patient who is going to respond to that medication and who is the patient who is not going to respond to that medication. So the data with baclofen are not necessarily homogeneous and consistent, but there are enough data, even with some still low level of evidence, so we need more data to suggest, like actually was done in this American College of Gastroenterology clinical guidelines, that the baclofen may be used to prevent relapse in patients with alcohol-associated liver disease. And consistent with the ACG clinical guidelines, also the American Liver Society, AASLD, has emphasized the possibility to use the baclofen as well as FDA-approved medications, specifically acamprosate, to treat AUD in patients with liver disease. So in fact, in this recent guidance from AASLD, they do emphasize the potential to consider pharmacotherapies and specifically acamprosate and baclofen in treating patients with AUD and ALD. And in a recent international consensus statement that we published a couple of years ago, we also emphasized that the data with baclofen are promising but limited. We also emphasize that there are some conflicting results, but nonetheless, baclofen is a potential pharmacological tool, in particular in specific settings, such as in the hepatology field, to help patients with alcohol use disorder. Now, switching gears, another medication that is promising is gabapentin. Gabapentin has not been formally tested in patients with AUD and ALD, but nonetheless, gabapentin has no hepatic metabolism, so there are no actually clinical reasons why gabapentin could not be used in patients with AUD and ALD. As many of you know, gabapentin is a medication that is approved by the FDA for seizures and also is approved for to control basically for neuropathy. But there are actually data indicating the potential role of gabapentin in alcohol use disorder. In particular, human lab studies suggest that the treatment with gabapentin leads to significantly greater reduction compared to placebo in cue-elicited craving. And also that its efficacy may be more pronounced in patients with more withdrawal symptoms. Based on this initial data by Dr. Barbara Mason and Dr. Ray Anton, more recently, Dr. Barbara Mason conducted a study, a treatment study, where she shows that the gabapentin dose-dependently reduces drinking and relapse-related symptoms such as a craving, insomnia, and dysphoria. And her team also showed that the gabapentin may reduce cannabis use, which is actually intriguing because there is actually a high comorbidity between cannabis and alcohol use disorder. More recently, a multi-site NAAA study, which was published in 2019, did not actually replicate the initial findings. This was a large study with almost 500 patients. And the question was why the data were not replicated. And of course, one easy conclusion would be that the gabapentin maybe does not work for alcohol use disorder. But there are also the reasons why we think that this large clinical trial was negative. One reason was that we used an extended release formulation, and we actually see that this extended release formulation led to lower concentrations of the gabapentin in the blood. So there was actually low blood concentration. So this could be a reason for the negative findings. We also saw in these patients that they had low severity of dependence, low levels of alcohol withdrawal. And if you remember from my previous slides, gabapentin seems to work better in patients with high withdrawal. And finally, as I point out before, for Baclofen, the same can be said for gabapentin. There's a high heterogeneity in the AUD population. This heterogeneity may be responsible for the lack of effect of gabapentin. And we actually have at least 2 more publications from 2020 that support the second and the third point. Regarding the second point, low levels of alcohol withdrawal, Ray Anton et al. Have recently shown that, in fact, the gabapentin is effective, but only in those alcohol-dependent patients with history of alcohol withdrawal and more withdrawal symptoms. So again, emphasize that maybe gabapentin only works in this subset of patients. And furthermore, Laska and colleagues performed a secondary analysis of the randomized clinical trial, and they applied machine learning method and random forest, and they found that the gabapentin was superior to placebo, but only in a subset of patients, specifically those patients who were defined as likely responders, defined as those predicted to have a reduction of at least 14 days. So again, suggesting that gabapentin may only work for some patients, but not for everybody. The third medication I would like to mention today is Topiramate. Topiramate is approved for seizures, for migraine. It also combined with phentermine. Topiramate was recently approved for obesity. It does have a partial hepatic metabolism. And one thing I want to mention is actually that Topiramate, again, like gabapentin and like Baclofen, has not been tested formally in randomized clinical trials in patients with AUD and ALD. And based on the pharmacology of Topiramate, actually this medication might be used in patients with liver disease. However, there is also one important clinical aspect to take into account, and I'm thinking particularly about patients with more advanced liver disease who also have hepatic encephalopathy, because Topiramate may give cognitive side effects. So giving Topiramate to patients with hepatic encephalopathy may be risky, because actually the Topiramate-related cognitive side effects may confound the clinical course and treatment of hepatic encephalopathy. So I would be actually conscious about using Topiramate in patients with more advanced liver disease, but think on the other side, the patients with less advanced liver disease may benefit from Topiramate. In fact, Topiramate is one of the medications for which we have seen in the literature the most consistent data, starting from this 2003 paper by Johnson et al., where they showed that treatment with topiramate compared to placebo was effective in reducing heavy drinking days. And starting from this single-site clinical trial, then Johnson et al. Published a follow-up multi-site clinical trial where, again, they found that the topiramate was effective compared to placebo in reducing heavy drinking and other alcohol outcomes. And after these two first clinical trials by Johnson et al., other studies have further replicated the efficacy of topiramate compared to placebo in treating alcohol dependence. And in fact, recently, people, in particular, Dr. Hank Kranzler, has been looking at potential moderating effect of this genetic polymorphism called the Greek 1. And they did find an effect of this polymorphism in one randomized clinical trial. They did not replicate their early findings with the second clinical trial, but even if they did not replicate the pharmacogenetic findings, overall, in these two clinical trials led by Dr. Kranzler at UPenn, they still did replicate the original findings regarding the main effect of topiramate in general in reducing alcohol drinking in patients with alcohol use disorder. As a matter of fact, the data with gabapentin and with topiramate are promising enough to the point that the American Psychiatry Association, APA, has included both gabapentin and topiramate in their recent guidelines, where actually in this practice guideline, they emphasize that these two medications, which again are not approved for alcohol use disorder, but nonetheless, they've been endorsed by the APA for patients who have a goal of reducing alcohol consumption or abstinence, patients who prefer topiramate or gabapentin because they are not tolerant or they are not responding to the FDA medications such as naltrexone and acamprosate. And also patients who cannot take naltrexone or acamprosate, so patients who have a contraindication. So for all these patients, the APA has been endorsing clinicians to consider prescribing as an off-label treatment topiramate or gabapentin. Now, all the examples I have discussed today are examples of such as Baclofen, topiramate, gabapentin, or potential pharmacological tools that we should implement to help our patients. But the final take-home message I want to provide today is the importance in general of integrating addiction and medicine, in particular hepatology, toward a multidisciplinary approach. That's even more important now that we have effective treatment for HCV. So alcohol, together with obesity, is going to be one of the leading causes more and more of liver disease. And the challenge we're facing that we don't actually do most of the times this implementation. For example, in this FDA study that was recently published, they showed that the number of patients who receive treatments for AUD is very small. But they also showed that if they do receive a treatment, these patients actually have better outcomes in terms of AUD and in terms of liver cirrhosis. So point being that we don't implement these treatments enough, but if we do, our patients may actually benefit, which means that we need to increase physician education addiction medicine. That's a clear message also from this recent survey from AASLD, where it's very important that we make our clinicians more comfortable in managing medications for AUD. So to summarize, basically, we do have medications approved, but we also have medications like Baclofen, gabapentin, and topiramate, which may be used off-label to treat AUD. But we still have some challenges, including the integration of a hepatology addiction medicine, and also the importance of increasing training in addiction. And of course, it will be important to increase research to discover and develop further more medications to help our patients. Thank you so much again, and I look forward to any question and comment. Thank you.
Muchas gracias, Dr. Leggio.
Thank you very much, Dr. Leggio, for that very interesting talk. I'd like to introduce Dr. Maria Ignacia Arteaga, psychiatrist in psychosomatic medicine and coordinator of the Soto del Rio Hospital of the psychiatry team at the clinical hospital of UC Christus Network. We've been working with her personally as well, so it's an honor to have her here.
presentar sobre la farmacoterapia de las
She'll be
comorbilidades.
doing with the pharmacological treatment of concomitant comorbidity. The floor is yours, doctor. Good afternoon. We'll be looking at treatment for comorbidity with AUD. First, I'll be going over the magnitude of this problem, the most frequent psychiatric comorbidities, considerations of psychopharmacological treatment, practical recommendations, and take-home messages. This graph represents the magnitude of the problem on a worldwide setting. This was reported in Lancet in 2019, where we can see that the figures, due to the pandemic, shifted. There was an increase in the consumption of alcohol, which led to several consequences in terms of psychiatric comorbidities, since this has been aggravated due to social isolation. Depressive thoughts will also be on the rise, anxiety symptoms. And there was a lot of misinformation. But indeed, alcohol consumption is significant. And together with the pandemic, these patients were far more at risk and far more vulnerable. Now, why should we care? You have a graph that shows lost years attributable to alcohol-related causes. We can see that in cardiovascular disease, digestive disease, there's a significant chunk, as you can see on the left. Substance use disorders we have as well, self-harm. So it's quite significant. Patients with AUD tend to also have severe mental disorders, which can predispose to greater rates of alcohol use disorder exacerbations. So there's a bidirectional relationship here, which is very relevant when performing a diagnosis of AUD. So when you get to the diagnosis, you should also actively look for other disorders. And when I'm talking about severe disorders, I'm talking about depression, anxiety, bipolar disorder, schizophrenia, post-traumatic stress disorder, among others. Today, we'll be looking at depression. You can see that there's an increase in you can see there's an increase in depression when there's an AUD. And about 30% of people in AUD, you could concomitantly diagnose depression. And likewise, in patients with depression, in 22% of those, you can also diagnose AUD. So there's a risk about of a factor of 2 of one disease when having another, which bolsters this bidirectional modality. Now, with anxiety, people with AUD could also have anxiety in 20 to 40% of all cases. Alcohol is a very powerful anxiolytic. It's the most powerful one, so it would be it's one of the most frequently used substances in self-medicated patients. Now, we've seen that AUD does lead to higher risk of social anxiety. And this tends to affect women more often. For PTSD, this is related to AUD in about 22 to 55% of cases. You can see the 55% particularly in American trials trials performed on war veterans from the Iraq War. And so AUD is frequent in that subgroup. Now, the PTSD tends to precede the AUD in the majority of the patients. The use of alcohol also decreases the ability to put into practice our coping mechanisms when dealing with trauma. In terms of schizophrenia and other psychoses, there's a significant association as well. There's an increased risk of psychotic episodes. We also know that patients with schizophrenia and other psychoses are especially vulnerable populations. So there's a significant association because, for example, someone with a disorder along the lines of schizophrenia with an alcohol disorder, they have a higher degree of their probability to adhere to treatment is lower. We can see associations in patients who have bipolar disorder type 1, and with AUD and bipolar disorder, there's a significantly increased risk of developing major cognitive disorders. When looking at other substance abuse disorders, up to 46% of the patients of the disorders due to alcohol will have associated a disorder of another substance. Now, if we consider the theory that alcohol could be a gateway drug, and it doesn't just work as a gateway drug, but there's also environmental factors which would make alcohol consumers more likely to consume other substances as well. Overall, when following the recommendations of the public health guidelines from England, they recommend that comorbidity when with AUD is the norm. So any setting would be the indicated one for, so there's really no wrong way to go about this. Diagnosis can be done in general, a GP can get to diagnosis, an internal medicine specialist, gastroenterologist. In terms of the psychoactive treatments, you have to think that we're dealing with patients that not only will have an AUD, but there'll be a lot of chances to have psychiatric comorbidity, and most of them will have a large risk of somatic comorbidity. So when choosing a psychoactive agent, it's important to take into account those three axes. Now, in patients with AUD and liver disease, you have to be clear that the pharmacokinetics of these patients will be altered. So there will be alterations in all of the processes under this function. Will be an alteration in absorption with redistribution. We'll have metabolic problems with the liver function itself. So patients where that we shouldn't lose when indicating treatment. Most of the psychoactive agents are metabolized in the liver. That's a concern that we have to consider in all from all the facets of medicine, be it general medicine all the way to psychiatry. Here we have a summary of the different types of psychoactive drugs. And I have 4 groups, which would be the most used clinically, which are indicated not from the psychiatric viewpoint, but from other medical specializations. We have antidepressants that have an extensive first step through the liver, SSRIs have greater safety. We don't recommend tricyclic antidepressants due to the high cholinergic risk and due to liver encephalopathy, and they're contraindicated in MAO inhibitors and so forth. In terms of antipsychotics, most of them require dosage judgment. Ciprasidone is very safe. We have to avoid some with high cholinergic index, so not the first generation ones. So you try to avoid those. And the second generation, we have to be careful with this index. Chlorpromazine is contraindicated. In terms of sedatives, we're talking about benzodiazepines. They move through the liver first extensively, so the recommendation is to avoid their use. However, where you have to use them, lorazepam, for example, would be the safest, since it doesn't have that first liver step. So its metabolization depends on other processes. Same can be said for others, oxazepam, so forth. In terms of anti-epileptic and mood stabilizer drugs, gabapentin and topiramate are the safest. There's a relative contraindication with carbamazepine and valproate. There's potentially hepatotoxic. And lithium, since it's, despite being an agent which isn't really dependent on liver function, it is sensitive to volume changes. So it has a therapeutic window, which is quite narrow. So it's essential to have close monitoring and to consider that drugs, for example, also alter its plasmatic levels, like the diuretics. So take into account interactions. So these drugs have the greatest risk of liver toxicity. Here we have MAO inhibitors, chlorpromazine, carbamazepine, duloxetine, valproate, bupropion, among others. In terms of practical recommendations, before leaving them on a psychoactive agent, you need to know that we're dealing with a patient who does have a condition, so who is complex when it comes to indicating psychoactive agents or any drug, where we have to take into account that it could be the cause of an alteration of greater risk of hepatic encephalopathy. So we have to avoid polypharmacy. So the less drugs we use, the better. The same applies for psychoactive agents. Look over safety info for each of the drugs you might be using. Try to consider a reduced initial dosage. With a lot of these psychoactive agents, you'll tend to start off with half of the indicated dose. Now, in patients where the half-life will be erratic, we should maintain longer intervals between one dose and another. That might be safer. We should avoid long half-life drugs. For example, diazepam. Its half-life is 100 hours, so in a patient with this kind of disease, it could be even longer. Or avoid drugs of prolonged release. So we have to monitor for side effects. Avoid the cholinergic drugs with a high cholinergic index. And this cholinergic index is sum with the other drugs that we use, not just in psychiatry, but drugs that are used outside of psychiatry. So we already need to calculate the summation of the cholinergic effect. We also should be careful with very sedative drugs. So that could lead to causing an encephalopathy. Finally, here we have some take-home messages. AUD has a high prevalence in the world, so it's something that we have to be concerned about. Comorbidity should be always taken as a rule. Alterations in pharmacokinetics are key when indicating any drug, especially when dealing with psychoactive drugs. You should consider that a lot of psychoactive agents aren't recommended. So you have to be very clear on the one you'll be using, which will be the best for the patient. And we have to lean on interdisciplinary work that we can do from the different spheres of medicine. Thank you very much. Here's my contact information on screen in case anyone has any questions. Thank you very much, Dr. Arteaga. Very well put together talk. Now I'll be moving on to the next phase. We'll have Dr. Arnold with us, a resident in gastroenterology, who's had quite a renowned track record during his residency. Has also worked in several alcohol-related studies. He'll be looking at clinical cases with us. We'll be looking at some topics dealing with AUD and liver disease, alcohol liver disease. And I'd like to take this moment to ask questions to our speakers. So, Dr. Arnold,
muchas gracias, doctor Díaz, por la presentación. Bueno, el primer caso clínico corresponde a un hombre de 51 años con antecedentes mórbidos de una cirrosis por alcohol, Child-Pugh B9, y además presentaba el año 2020, tuvo un episodio de una hepatitis asociada al alcohol grave, que no tuvo una respuesta a corticoides en ese momento. Y a pesar de este mal pronóstico determinado por este cuadro bastante severo, el paciente se logró ir a su casa, estuvo en su domicilio y posteriormente recibió medicamentos con lactulosa
and received lactulose,
spironolactone. Con su esposa, presentó abstinencia de consumo de alcohol en los controles ambulatorios que fueron confirmados por su
outpatient follow-up confirmed by their family. And on imaging, we detected a right renal mass being followed up by urology. All of this occurred over the course of 1 year. Now, in one of these neurological, there was a bit of bad psyche, jaundice,
y en forma remota el urólogo empieza a pesquisar que el paciente había retomado su consumo de alcohol de un litro de vino al día,
had a relapse about 1 liter of wine a day,
un poco de ictericia, junto con
and the family noted he was a bit with jaundice and slurred thought.
Dentro de su laboratorio, el derivado de la urgencia, se pesquisa con una ictericia considerable, con una bilirrubina total
significant jaundice, total bilirubin,
fosfatasa alcalina de 222,
alkaline phosphatase 222, GGT88, transaminases are elevated,
295 con una GPT de 137,
GOT is 205, GPT 137, INR 2.4,
y se pesquisa en su imagen que presenta un hígado nodular. Y además se puede ver también la neoplasia renal en esta imagen junto con su esplenomegalia. De esta forma se conforma el diagnóstico de una hepatitis asociada al alcohol grave con un MELT de 35
alcohol
y que hepatitis
no fue severe one, MELT score of 35 does not respond to corticosteroids.
El doctor Díaz va a continuar con algunas preguntas.
So Dr. Díaz will continue with some questions.
Bien, entonces aprovechando este interesante caso, a comenzar preguntándole
Let's begin. Dr. Roblero,
¿se podría haber prevenido este episodio?
Could this episode of alcohol hepatitis have been prevented? And what we should do as gastroenterologists? And what could we do to prevent it?
Gracias por la pregunta, Luis Antonio.
Thank you, Luis Antonio. I believe that indeed
demostrado que la terapia
it has been shown that
con intervenciones breves,
that treatment with short interventions or
son efectivas,
with motivational enhancement therapy, TM, and the association with pharmacological treatment is even greater. So using
psicológica o
psychological treatment
de psiquiatras
with a team of psychiatrists who deal with addiction more than using medication. Well, it wouldn't have been 100%, but we would have been able to avoid a significant percentage of these. That's what we should have done.
Súper. Me gustaría aprovechar de hacerle una segunda pregunta.
Now, here we have a second question. In clinical practice, how can we get the patient to commit to the treatment for AUD? Now, what I had mentioned in my talk, we have to be interested ourselves first in helping them. And in studies mainly in Europe and the US, physician interest in treating the patient isn't that high. Many physicians have noted that they don't have the clinical tools to do it, so they would require support. And our country would be no exception. And the lack of multidisciplinary teams to which we could refer these patients, where a psychiatry team could intervene and so forth. So there's a lot of patients with alcoholic hepatitis that we can't really put through that system to see psychiatrists. So having that sort of network would be essential, multidisciplinary. Now, to get the patient to commit, as a general practitioner, or with a nursing team, or with social workers, you can work in the brief interventions. That could be an initial phase. Developing the abilities I talked about. There's an aspect from the spirit of the interview. Our attitude has to be full of empathy, as mentioned, which has proven to be effective. Basically, trying to put yourself in the patient's shoes and to make them reflect on their problem or condition. We can't really force them. You have to develop communicational skills, which would be summarized in OARS. With these 10-minute sort of visits, we can get the patient to reflect on their situation in terms of how to get them out, get them pull through. So this could be useful. We also have to try to have a multidisciplinary team, psychiatrists, social workers, and so forth, to help deal with these patients.
La siguiente pregunta que me gustaría hacer es para la doctora Sofía Herrera.
The next question is for Dr. Sofía Herrera.
En su presentación, pero me gustaría si pudiese ampliar.
She touched on this in her presentation, but this is about the old classification from the DSM. It talked about dependency and abuse. And how is that language incorporated in the current definition? And what implications would there be in clinical practice? Really with your feet on the ground, so to speak. Well, as I was saying in the presentation, in the DSM-5, these criteria were unified dependence and abuse. We took off the criteria of legal consequences and we added cravings, which had been mentioned in other presentations today. And in terms of abuse disorders, mild, moderate, severe, and based on treatment continuity, this would be the novelties. Now, why were these changes made even? Well, there are several reasons, but mainly because the research team from DSM saw that it really wasn't worth it, and it would take off diagnostic validity in abuse, when treating them in a hierarchical fashion. For example, a patient with dependence would be a patient who was more severe, and the legal, social consequences or work consequences weren't as severe. So it's useful to have a common language in order to use specifiers and to formulate their severity level and to not leave patients out of the loop. Thank you very much. Next question is for Dr. Bessone, and it's with the transplant, deals with transplant. How do you recommend evaluating abstinence in patients who would be potential transplant candidates? There's a high rate of relapse post-transplant. This figures can be as high as 30% and up. However, there are two situations that, at least in our experience, one would be the first episode of alcoholic hepatitis. A lot of the people who go off alcohol, if the patient isn't motivated, well, they won't go off alcohol easily. So the first episode, if they feel terrible, for example, and the second would be the transplant, because they've got a lot of anxiety, expectations, they fear that it might go wrong. Now, there I'd like to fall back on what had been mentioned on the multidisciplinary team. I can't say no all of the hospitals of Latin America, but there would be a deficit in one or another in close follow-up, even with social workers incorporated. If the patient has high motivation, it's much easier. I've had patients that were very firm and were dead set on it. The last one we transplanted is in good state and hasn't had any relapses. So that's where we can see the group of that's where you can see the fruits of teamwork. Thank you very much, Dr. Bessone. The next clinical case.
El siguiente caso es un hombre de 23 años que tiene antecedente a su temprana edad de una cirrosis de una probable y también un poco dudosa etiología de alcohol, en que su debut fue una hemorragia digestiva alta varicial, llegando bien grave como posteriormente. Dentro de sus otros antecedentes no tiene antecedentes quirúrgicos, no presenta utilización de fármacos ni alergias y tampoco antecedentes familiares. Sin embargo, destaca consumo de alcohol desde los 14 años, en que en relación a su consumo, un consumo considerable de al menos 3 litros de cerveza en forma diaria. A veces también podría haber consumido destilado en forma intermitente. Consumo de tabaco, 10 cigarros al día en promedio durante toda su adolescencia. Y además consumo de marihuana, pasta base y cocaína en forma intermitente.
Crack cocaine and THC daily.
Solo regular y trabaja como operador de maquinaria pesada. En este escenario,
operates heavy machinery and has a regular
varicial, finalmente el paciente desarrolla una falla hepática
the patient after this bleed
con un MEL sodio
had
an
chronic or acute over chronic liver failure, ALCF3, MEL score 40,
y conlleva finalmente
hepatorenal syndrome, cephalopathy grade 4. And there was a ventilatory failure and eventually hemodynamic failure.
En este escenario de gravedad se evalúa en forma multidisciplinaria y se decide un trasplante hepático donante cadáver. En su inmunosupresión inicial con metilprednisolona y basiliximab tiene una buena respuesta
methylprednisolone and
y tiene una evolución clínica que es bastante favorable posteriormente.
Very favorable subsequent clinical progression. Vasoactive drugs were taken off after 2 days. After 3 days was taken off mechanical ventilation and renal function progressively improved.
Siguiente, por favor. Sin embargo, la anatomía patológica del
However,
explante resulta
the
compatible con una
explant
hepatitis
pathology
autoinmune.
report was consistent with autoimmune hepatitis. Thank you, Dr. Arnold. This was quite a challenge because we are dealing with a higher risk patient with significant consumption of alcohol and other substances. And it also turned out but autoimmune hepatitis. So it's quite challenging. And it leads us to really ask about the burden of alcohol, how it affects the patients, what would be the support network they're dealing with. If there's any recovery potential, patient is still abstinent and with normal liver tests. I have some questions based on this case. First is for you, Dr. Winter. And it's if in resistant patients who do not require psychiatric treatment, how can we do as gastroenterologists to help those patients? Dr. Winder.
So I think one of the secrets is that patients believe their liver doctors more than psychiatrists or psychologists. So even if the primary cause of this case was not alcohol, hearing from the transplant surgeons and the hepatologists about the importance and harm to the graft from alcohol is still highly, highly relevant in this case. Progress notes and documentation should maintain alcohol as a risk. It should not disappear or fall away from medical documentation. It should remain a clinical priority. And it's a great example of alcohol plus, how alcohol travels and stays with patients of many different diagnostic categories. So ideally, as a proponent of integrated care, there is a close connection with mental health, where a hepatologist not only has her own knowledge base that she's transmitting and collaborating with the patient during each clinic visit, but is referring and building bridges to a mental health provider to look at that history and risk, near-term or long-term, of tobacco, cocaine, marijuana, and alcohol. I would argue that that is just as relevant as adherence to tacrolimus and other immunosuppressants. It is just as relevant to maintain toxicology surveillance as it is to get tacrolimus levels. And I think the field needs to prioritize, particularly in patients like this, where the patient will not have the investment that my liver disease was caused by alcohol. That is a major psychological motivation for patients. So when it's autoimmune like this case, it only increases the priority and the importance of the hepatologist mentioning, following up with the patient about substance use as a health behavior, whether or not it's an addiction according to the DSM.
Muchas gracias, Dr. Winder. Muy interesante.
Thank you very much, Dr. Winder. Very interesting, and also a challenge we have before us in our different liver and transplant centers in Latin America. Next question for Dr. Santis and Leggio, in terms of their presentations. If you could give us sort of the roadmap or the recipe for habitual use medication, in the case of Santis, the FDA approved ones, and for Dr. Leggio, the ones that aren't FDA approved.
Bueno, a ver, primero que nada, algunos comentarios.
First of all, some comments on the case. Indeed, we're dealing with a young man who had an early beginning in alcohol and drugs. We know that the prognosis in AUD gets worse when regular alcohol consumption occurs before the age of 15. Their severity and addiction severity tends to get worse. Even more so if that individual has other disorders due to other substances, as was this case. Now, on that vein, considering what Dr. Winder said, that this patient, being young, understanding that the liver damage was autoimmune, it's highly likely that this patient will retake their alcohol consumption. In practice, what we see is that after an initial period where the patient will be perhaps more supervised by the multidisciplinary crew and by the family, their support network, but as they become more autonomous, and this is a patient with a job, patient is difficult to control really because the patient makes his own money. So this is a long-term patient. You have to be with them for the long run, with interventions taking into account both psychosocial, pharmacological as well. Now, the drugs which are approved by the FDA, you might initially think based on how liver function is, how it's progressed post-transplant, and you might think that the first option would be a camprosate. It's an agent that overall allows for prolonging abstinence, except for the initial complications. It's otherwise well tolerated. Now it has to be 3 times a day, of course, a camprosate, but when patients, when they respond, they can see that their desire for consuming alcohol has decreased. There's a desire to maintain abstinence. Now, this is a patient who, due to their dubious motivation, or motivation based on the age group, might be variable. Disulfiram is something I would leave as a third-line treatment. The drug that you could possibly use, naltrexone, based on how the transplant goes over time. So we'd want to pharmacologically not harm the liver, try to go past it. So that's how I would proceed. Thank you. I'd like to ask Dr. Lijo on his opinion on what non-FDA approved medications would be potentially useful in this patient. Perhaps not at the acute phase, but if you'd give us sort of like a kitchen recipe on the drug you'd use.
Yeah, sure. And sorry, I had an internet problem. So at some point my Zoom shut down and I was not able to turn on the camera. So I apologize for the connectivity issue, but I'm back now. Yeah, so I think as you point out, I think this will be a case where you may want to first clinically stabilize the patient before considering a medication, in particular, one of the second-line medications as the ones that I briefly, summarized today. I would say, today I spoke about Baclofen, Gabapentin, and Topiramate. And I think for this patient, one thing you want to do is, of course, as Dr. Santos pointed out, to look at the liver function, but also to look at the kidney function as well, right? Because all these 3 medications, Baclofen, Gabapentin, and Topiramate, have primarily a renal excretion. So you want to make sure that there is, there is actually a kidney function that is proper before starting the administration. And also you may consider, based on the creatinine and primarily creatinine clearance, to possibly adjust the dose of the medication. For the reasons I mentioned during my talk, which is the potential risk of topiramate to actually cause cognitive dysfunction for some patients, I think I will keep the topiramate as maybe the last resort, so to speak. So I think I will focus for this patient on using either Gabapentin or Baclofen. As we know, there is more literature on the Baclofen, so Baclofen may be the safer choice just because we have more data on the safety of the administration of Baclofen in patients with liver cirrhosis. But nonetheless, I think Gabapentin will also be an important potential medication to consider. One question would be, once you start the medication, to do a slow titration and to see whether patients may respond well, but and not just in terms of efficacy, but also in terms of safety, in particular in terms of sedation. Both Baclofen and Gabapentin may give a sedation. So it is true that the patients with alcohol use disorder tend to be less sensitive to the sedative effects of these medications compared to patients without alcohol use disorder. But nonetheless, I think either you go with Baclofen or you go with Gabapentin. I would be careful to do a slow titration to monitor carefully the potential sedation sleepiness. So that will be kind of my approach. I think likely I will start with Baclofen, possibly consider Baclofen. I will think for this kind of patient, I will stay away from Topiramate. Also, one medication I want to mention that I did not present today, and this is back to one of the comments from Scott, from Dr. Winder, is about smoking comorbidity. And with that in mind, varenicline is actually a medication approved for tobacco use disorder. Actually, there are some data, not as robust as Topiramate or Gabapentin in terms of data, but there are some promising data, including a clinical trial with roughly 200 patients. Citation is a Relitan et al. In the Journal of Addiction Medicine. And that paper suggests that the varenicline may be helpful in reducing alcohol drinking, and also suggests that the smoking comorbidity, which doesn't surprise, but it's great to see through data analysis that smoking is actually a predictor of response. So meaning that varenicline may reduce alcohol drinking in people with alcohol use disorder and smoking comorbidity. This also brings some potential mechanism because it's possible that the varenicline may help to reduce drinking via smoking, so smoking be a mediator of the effect. The only caveat is that, with Baclofen, we have some potentially promising data on the Baclofen be able to promote and maintain abstinence. We have some data with Gabapentin as well in that regard, although they're more limited. The stronger data with varenicline are more toward the reduction in the drinking that are definitely important, in particular in terms of harm reduction. But in the context of a patient with advanced liver disease, we really want to focus on abstinence, not just in the reduction. In this case, we also want to focus in preventing relapse. So these are an additional consideration. Also, last thing I would say, think about how we treat H. pylori, or how we treat, hypercholesterolemia, chronic heart failure. We give them multiple medications. I'm the first one that does study one medication at a time because my clinical laboratory focuses on early discovery, so early phase 1, phase 2 studies. But when we think about pharmacotherapy in clinical practice in large populations, the idea of only using one medication for such a complex medical disorder is just not going to fly. Just like we give multiple medications for people with metabolic disorders, even we give it 2 medications, often a combo of 2 medications just for cholesterol, we had to think about multiple medications. So point being that for this patient, in general, for patient with comorbidities, I would consider, for example, combination of, let's say, Baclofen and varenicline, just as an example. Thank you so much.
Muchas gracias, Dr. Leggio.
Thank you very much, Dr. Leggio. We have the last question from that case. related with comorbidity, and it's for Dr. Arteaga. Depression is very common in these patients. So the question is, what medication would we prefer, would be preferable to use in this scenario for treating comorbidities? Thank you for the question. The greatest safety, the ones that we have the most experience on, and in terms of what's been seen in the presentation, it's the cases where you could, those are the cases where you could start with more confidence. There's greater sertraline is good response. Escitalopram is also quite safe. So we have to be aware of what drugs we can and cannot give. Tricyclics, for example, avoid. Sertraline, escitalopram, SSRI seem pretty safe. We have to take into account the dose, but it would be the safest group right now.
¿Podría hacer un comentario corto?
Could I tack something on, Luis?
¿Se escucha? Se escucha. Adelante, doctor Bessone.
Go ahead.
Claro, yo quería hacer un comentario corto con respecto al paciente.
This is in terms of a patient who consumes cocaine and who consumes alcohol. So the hepatotoxic potential is interesting because it's the same P450C cytochrome that deals with both. And there's few studies in terms of the cocaine and how it behaves with high dose of alcohol, because we know that cocaine is hepatotoxic, even in the absence of alcohol. And there's a metabolite created between alcohol and cocaine, which can be individual metabolites. So in a patient who over time became child C, who was taking a hepatotoxic drug with albumin disorders in bile flow, these patients have cholestasis, hyperbilirubinemia, liver failure. So these would be high risk factors for hepatotoxicity, for liver toxicity. So it's not the same patient where it's a child A and Baclofen. These are patients where we've seen protease activity in Hep C, drugs in a normal liver. It's not complex, but when they have all these other factors, or if they're cirrhotic, for example, well, in phase 1, in the cytochrome, there's a decrease in the metabolism due to the cirrhosis. So it shifts the scenario. We could lower the dose, but there's no trials. And what can happen with these drugs in the hepatotoxic plane, and this is something we'll see as we treat. Thank you, Dr. Bessone. I'd like to add that this is a very complex case. It made us reflect a lot as a transplant team to look at consumption patterns to ensure that this was a reasonable candidate. Both the patient and the family were able to overcome those barriers. And fortunately, the patient has had favorable progression as of now. We'll be moving on to a second phase. We have audience questions. The idea is that this be in a Q&A fashion, short, brief. So, Dr. Arnold, you may read out the questions. Thank you, Dr. Diaz. We have a question for Dr. Winder. In terms of discrepancies in AUD, is there any special consideration in clinical practice with this topic in terms of ethnicity, race, especially in the United States? That's an audience coming from an audience question, Dr. Winder.
Is this an epidemiology question about discrepancies of alcohol use disorder? I'm not sure I grasped the question.
Sí, o si es que hay que tener
Yes,
probablemente.
or if we have to have a cultural question, if we need to have any different approximation based on the different ethnicities, or how do you consider this cultural factor more than ethnicity when dealing with these kinds of patients?
Yeah, it's a great question and an important question. I think any psychiatrist will prioritize understanding quickly what the patient's previous experiences have been with the health system. So there may be very careful conversations that we have to have about trust if people have been previously disregarded or their pain complaints or their agency has been adversely affected by previous clinicians. That is something that any psychiatrist will want to understand very quickly. In terms of time with a patient in the room, we need to be aware of any cultural sensitivity about gender, the gender of the clinician. Some of the words that we use very quickly to describe a patient's drinking may have very difficult connotations and may affect the patient in unique ways because of their culture, where they're coming from. And the actual disclosure of the alcohol use disorder itself may not have ever occurred. And depending on the culture of the person, what we do with that information, meaning how we discuss with the family why the patient is being transplanted, why we are making the treatment recommendations that we are, becomes very delicate. And as I said in my presentation, I really would like the audience to appreciate that the words we use, the people we are, how we understand cultures, how we relate to different cultures, how we invite the trust of different people from different cultures is every bit as important as the tools in the operating room, as every bit of important as the tools in the intensive care unit. And particularly with alcohol-related liver disease, that gentle, technical, personal approach we have to people of different cultural backgrounds is of the highest priority in this work. Thank you for that question.
Muchas gracias por la respuesta,
Thank you,
Winder.
Dr. Winder.
Tenemos otra pregunta para la doctora Herrera.
For
Una
Dr.
pregunta que se
Herrera.
conforma en dos, por decirlo de alguna
It's a
manera.
two-part
Primero,
question.
¿cómo se diferencia entre
How do you
slip y recaída
differentiate
en el
between
consumo?
slip and
Y la
relapse?
segunda parte es si
And
existe alguna
second part,
forma
if there's
de
any way
medir la
to
introspección del
measure
problema por parte de los
introspection of the
pacientes.
problem on the patient's
Esas son las
part.
preguntas, doctora.
Bien. Muy buena pregunta. Claro que hay diferencias.
Well, there's differences between a slip and a relapse. Dr. Santis might be able to explain it better than I could, but the slip is would be the first consumption after maintaining abstinence. It would usually be bad decision making, to expose themselves to high-risk situations. For example, going back to with an enabler. So going back with groups of enablers and going back to consume. So with a relapse, the relapse is back to the habitual pattern of consumption. It would be a consequence of having planning. It's not just bad decision making. Now, the interesting thing is that between slip and relapse, there's a transition process where several psychological processes occur. But in the case of the patient, to be able to deal with this suitably with their coping skills that are trained within psychotherapy, or with occupational therapy, family therapy, and so forth. Now, it's possible for a slip not to turn into an actual full-blown relapse. So when dealing with a slip, nipping it in the bud, which is to say, putting them in touch with my team to ask for family help, to not go back to the enabling situations. So that way we can decrease things like feelings of guilt and so forth. We can lose a lot of patients to that too. So as all of the speakers have been saying today, granted, we've talked a lot about psychoactive drugs, but psychological treatment per se is fundamental in our long-term strategy. And in terms of part two, in terms of insight, of the insight, the awareness of the patient, of their condition, truth be told, this is looked at during throughout the different visits when they meet up with a psychiatrist, for example, or with a psychologist. It's what the family members will be referring during the family round of treatment. And as mentioned by the speakers, Dr. Santis, in terms of the last clinical case, the case number 2, the young man, the motivation and awareness of the condition can have an impact on your treatment. So as clinicians, we have to be very sharp in terms of sensing when motivation is dropping or when awareness of the disease is dropping. So we can apply motivational enhancement therapy, which Dr. Winder had mentioned and other presenters had mentioned, and to go back on it with the patient and their family. Thank you very much, Dr. Herrera. The next question is for Dr. Juan Pablo Robledo. We were asked if a nutritionist has asked, can a nutritionist participate and do the 12-step interview with the patient to understand the level of addiction and to help them? Can the nutritionist do that at any point? In principle, yes. Trained health personnel can take part in those brief interviews, yes. You can see this on videos that I had shared with you. These workshops are done with Canada, the United States. Surely Dr. Scott Winder could also corroborate this, because all this information is available of health professionals who are actually qualified after training to do this, yes. I don't know if Dr. Winder would like to tack on something to that.
I sound a little bit like a squeaky wheel saying the same thing over and over again, but the more that we share this expertise, the better we are. So as a psychiatrist, understanding hepatic encephalopathy, being able to read a comprehensive metabolic panel, being able to speak the language of my hepatology colleagues just makes me a better doctor. So I take Dr. Robledo's statement as fact that any healthcare professional, arguably those with medical training, are more important initially because the patients understand, many of them, their condition medically before they understand it psychologically. So I think motivational interviewing for all health providers only helps us to help our patients with their behaviors quicker and with better outcomes.
Muchas gracias, doctor. Tenemos la siguiente pregunta del público para el doctor.
We have an audience question.
Sí, ¿es posible o es factible combinar medicamentos para el tratamiento de estos pacientes? ¿O su combinación pudiese tener un efecto sinérgico beneficioso?
This combination might have a synergic effect, which could be beneficial. What would be your opinion, Dr. Leggio?
Right, yeah, excellent question. I guess it goes back to the comment I made earlier. So, you know, of course, you have to be careful about potential drug-drug interactions, safety, liver kidney function. That all said, in principle, in practice, yes, it is possible actually should be done. Again, I think it goes back to what we were talking before. Think about a patient with diabetes, hypercholesterolemia, chronic heart failure. These patients take an average of 10 medications per day. Think about a patient with cancer. These patients take multiple medications. So yes, like I said, some of the early work was on a single medication in clinical trial for good methodological reasons, because these are proof of concept. But eventually, as we try to translate addiction science to addiction medicine, addiction psychiatry to practice, combining medications with different, mechanism of action, and also based on different comorbidities, is really, really critical. So I will definitely encourage clinicians to really, try to find your comfort zone, but really try to combine medications, see what works more in your clinic. Sometimes based on clinical judgment. I think the easy example I made before is varenicline because of its approval for smoking, but that's just one example. For example, there is also important comorbidity between alcohol use disorder and obesity, which also leads to a comorbidity at the liver level, because then you have this metabolic liver disease where you have both NASH and alcohol contributing to the liver failure. In that regard, medication like a Topiramate would be something to definitely consider, because it's a clear effect in helping people also to reduce appetite and to lose weight. So yeah, I'm happy to elaborate more, but I think the idea of combining medications, it also, of course, let me emphasize, combine medications and combine multidisciplinary treatments also with non-medication treatments, such as behavior treatments, is really critical. In clinical research, it is a little difficult answer sometimes to formally address in a clinical trial, because you really need big sample size. So it's not easy. We do like investments from the private sector to invest in addiction. So that's definitely a challenge we have. And also thinking about the methodological design, when you go with these larger trials, thinking about how you design your clinical trial is important. For example, years ago, the combined trial was a gigantic effort, and it did provide important information, but it was kind of a detached from clinical practice, because in clinical practice, you don't do that really intense, just not enough research to do CBT and medications and medical management. So in a sense, what happened with the combined study, everybody really had great outcomes, which is good, but we were left with some unanswered questions because there was a gigantic treatment effect, which you don't have in clinical practice, a really inability to have enough delta variation to disentangle potential difference or synergistic effects of, for example, CBT and medication. Thank you so much. That was a great question. Thank you.
Muchas gracias. La siguiente.
Thank you very much. Next question is for Dr. Santis. Very simple, but now, as gastroenterologists and hepatologists, is there any medication of the ones that we're authorized to use, so the mentioned ones, what would be the safest one for us to indicate?
La pregunta es para mí porque no escuché.
Es para el doctor Santis.
It's for Dr. Santis.
La verdad que los tres.
Truth be told, the three drugs can be used by not just psychiatrists who specialize in addictions. It can be used by general psychiatrists and gastroenterologists. We have to be clear on the administration protocol, because all of these medications have side effects and complications which can be exacerbated with naltrexone, Disulfiram. We need liver tests with acamprosate.
Se escucha bien. Se escucha bien.
Yes, we read you. With acamprosate, we have to look at the renal function and liver tests with the first two. So instead of just leaving certain drugs to specialists, the clinician who will be using these medications has a responsibility of becoming familiar with a determined protocol, and that protocol is the one you'll have to follow. So along those lines, any professional who wishes to administer these drugs rigorously can do so. Thank you. For Dr. Arteaga, since insomnia is so frequent, to common in these patients, if you had to pick a drug, which would you use? Indeed, insomnia is quite common. It's very important to see if it's primary or secondary insomnia. And we tend to overuse quetiapine, despite the fact that it could be a drug that could be used in low dose and it could be safe. We have to take into account what had been commented about its anticholinergic effect and other drugs which have been mentioned throughout this afternoon, such as gabapentin. You have to, if it has been indicated, well, we have to make the most of these side effects, which are the same that we have to be on the lookout for. For example, sedation. We know that the patient has good renal function. It's quite safe. Well, we're using it in a secondary fashion to keep them on abstinence. So I would use that one. That if it's part of the plan due to the availability and due to availability in your country or region.
Muchas gracias, doctora. Una pregunta para el doctor Winder.
Another question for you, Dr. Winder. In the setting of hospitalized patients, when do you consider that it would be the best time to call on the psychiatry team? What would be the best time, the most opportune moment, or the importance in the family interview?
Yeah, I think the paper by Dr. Azrani from the Dallas Consensus regarding guidelines for acute alcohol-associated hepatitis really zooms in on this idea that if this is a patient who is going to be considered for transplant, if I understand the question that it's a transplant evaluation, a psychosocial transplant evaluation, that interview should take place very quickly before mental status changes and ICU transfer happen. Many centers who do a lot of this will have the psychosocial interview take place by the social worker, psychologist, or psychiatrist early, even before some of the more intensive procedures to maximize the quality and quantity of that information. So that would be one just general guideline and timing. With regards to family, it's important with confidentiality that the patient at least be given the information and have the ability to consent if we speak to family. Mental health and addiction information is highly guarded in terms of confidentiality, and it's ethically and legally appropriate to make sure that we have obeyed and considered patient wishes when it comes to seeking collateral information, which we must seek in every case. With regard to non-transplant inpatient assessments, I think any time is good. Inpatient alcohol-related liver disease patients are so tragically undertreated in the hospital. I really think that any interaction with a peer coach, social worker, psychologist, or psychiatrist at any time during that evaluation is a gain, a benefit for the patient and the health system.
Muchas gracias.
Thank you very much. I'd like to wrap up. I'd like to thank our speakers. Very enlightening talks. I learned more today than on this issue than in my entire medical training. So I hope this has also been fruitful for the rest of the attendees. Thank you once more to the speakers, to Aleh, ALEH, the special interest group in alcohol liver conditions. for giving us a chance to hold this activity. And I'd like to thank Tiva, who gave us the financial support for holding this event. Now, if you missed anything, these talks will be available on the Aleh site. They'll be available about a week from now. Thank you very much for being with us today, for your support, and hopefully we'll be seeing each other soon.